As people trickle in, good morning. Thank you for joining us. I'm Rebecca Rodriguez. Before we get started, I would like to make a few housekeeping announcements. Please note that this meeting is being recorded. Microphones and cameras have been disabled. Please use the Q&A feature to post your questions and comments, and we will address them during the Q&A portion for each corresponding session. And we will also follow directly in the Q&A feature as feasible. If you have technical difficulties or need assistance during this workshop, please reach out to Danielle Janigan, and email address is right here. Danielle, if you can post that on the chat as well. Next slide. To get us started, I would like to introduce Dr. Gregory Germino, our NIDDK Deputy Director, for some welcoming remarks.
Thank you, Rebecca, and good morning. On behalf of the National Institute of Diabetes, Digestive, and Kidney Diseases, and our director, Dr. Griffin Rogers, I'm pleased to welcome you to the NIDDK Interoperability Workshop, addressing gaps, challenges, and opportunities related to data and metadata standards for NIDDK research priorities. I am delighted to see such a varied and esteemed audience has registered for this workshop, including colleagues from across NIH, academic researchers, data scientists, fellows, and trainees. Your presence signifies the importance of our collective mission to enhance data interoperability for both primary and secondary use within the NIDDK research mission areas. I especially want to extend a warm welcome to the speakers, moderators, and panelists. One important objective of this workshop is to identify and explore opportunities for collaboration for establishing, implementing, and consistently using standardized terminologies and common data elements, also known as CDEs, critical to advancing research in diabetes, obesity, nutrition, liver, digestive, kidney, urologic, and hematologic diseases. We have a very broad portfolio, as you know. And as was mentioned earlier, the workshop is being recorded, and the recording will be available on the NIDDK YouTube website. So please share the information with others who may be interested in the topic, but were not able to attend today. As all of you know, NIH has a long-standing interest in enhancing the value of data by promoting its reuse so the scientific community can better benefit from its often unrealized intrinsic value. Just last year, NIH issued a new data management and sharing policy that requires investigators to prospectively consider how their results can be shared in a meaningful way with others. As important as this policy is to enhancing our data share environment, it is but one element necessary for a robust data science ecosystem. Community-adopted data and metadata standards are also critical for effective data sharing and integration across various domains. It is particularly important in the area of artificial intelligence. However, we often encounter significant inconsistencies in disease-specific measures within and across clinical studies. These variations in data collection, specifications, and representations pose substantial challenges for integrated secondary data analyses. This workshop is our opportunity to confront these challenges directly, promoting interoperability and fostering a collaborative environment where data can be seamlessly shared and utilized to its full potential. Over the next 2 days, we will engage in meaningful discussions with our community partners, identify existing gaps and challenges, explore opportunities for developing new standards, and outline actionable next steps to encourage the development and adoption of data and metadata standards for relevant data types. We are privileged to have an outstanding lineup of speakers and panelists who will share their insights and experiences. Our agenda is packed with informative sessions, including keynote addresses, moderated presentations, panel discussions, and interactive Q&A segments. To start our day today, we'll hear from Dr. Mark Clemens, who will deliver a thought-provoking keynote titled, "The Land That Time Forgot: How Bridges to Nowhere, Abandoned Tracks, and Sinkholes Stand Between Us and the Diabetes Care we deserve, and importantly, how to fix them. Following this, we will delve into success stories in data collection, integration, and interoperability, and many sessions by research areas, followed by a cross-cutting themes panel discussion. Making all of this possible is a diverse group of experts who have agreed to participate in the various sessions. In closing, I want to thank all of our speakers for their many contributions to the success of the workshop. I also want to thank our meeting organizers, Drs. Gossett, Jia, and Ravichandran, and Dr. Rodriguez. I also want to thank Ms. Sharon Lawler and the NIDDK Data Science Working Group for their dedication and commitment to this important initiative. Your expertise and contributions are invaluable as we work together to promote data interoperability in NIDDK research mission areas. Finally, I'd like to thank all of you for your interest in this workshop and shared commitment to making significant strides in data interoperability. Thank you once again for being here, and I look forward to the engaging discussions and fruitful collaborations that lie ahead. Rebecca?
And thank you, Dr. Gemino. We will move now to the first session of the day, where we will discuss the areas relevant to NIDDK research priorities. We will also discuss success stories, as well as the establishment of and implementation of standardized terminologies in data collection, including wearable device data. This session is chaired by Dr. Guillermo Arreaza Rubin and Dr. Roy Beck. Dr. Arreaza Rubin is the Program Director of the Clinical Immunology Diabetes Program and the Technologies of the Diagnosis and Diabetes Control Program at NIDDK, and oversees a variety of research projects designed to improve diagnosis, treatment, and monitoring of the disease. Dr. Beck is a physician and epidemiologist with over 35 years of experience in clinical trials. He founded the Jaeb Center for Health Research, a nonprofit coordinating center in Tampa, Florida, established in 1993. His child's type 1 diabetes diagnosis has shaped the center's focus and his research. For over 20 years, he has managed initiatives like the NIH-funded Diabetes Research in Children's Network, the JDRF-CGM randomized trial, and the Pediatrics Diabetes Consortium, along with CGM and insulin delivery systems supported by NIH, JDRF, the Helmsley Charitable Trust, and other private industry. Guillermo?
Okay, thank you very much, Rebecca. So it's a privilege to me to introduce Mark Clemens. He's going to be the first keynote speaker. Dr. Mark Clemens is a pediatric endocrinologist and professor of pediatrics at the Children's Mercy Kansas City. He also serves as chief medical officer at Gluco. He previously held leadership positions in the Type 1 Diabetes Exchange Clinical Registry and the T1D Exchange Quality Improvement Collaborative. He is currently a trial and clinical center director. He also leads the Rising Tide Alliance Initiative, which is an initiative to positively transform T1D care using data science, predictive analytics, custom population health management software, and also an innovative diabetes rapid learning lab concept that leverages remote patient monitoring and a curated library of digital first behavioral and care delivery interventions. So Mark is going to talk about the title of his presentation, as Dr. Gemino mentioned already, is The Land That Time Forgot: How Bridges to Nowhere, Abandoned Tracks, and Sinkholes stand between us and the diabetes care we deserve, and how to fix that. So welcome, Mark, and go ahead with your presentation.
Thank you so much. I really appreciate the introduction. Let me share my screen. And, oh, sorry, it's the Zoom is blocking my view here. There we go. Okay. You can see my slides okay?
Yes.
Yeah.
Perfect. Thank you so much again for the kind introduction, the opportunity to be here. a few disclosures. One, I'm not a bioinformaticist. I am certainly not a data scientist, but I have learned how to interact with these folks and to really think about how to translate into the world of research, clinical research, and clinical care. So I'm going to be speaking from that perspective. These are my disclosures. And then I just want to thank Juan Espinosa, who's our next speaker, with whom I work closely and whose images I borrowed for a few of my slides. Juan and I tend to steal shamelessly and share seamlessly with each other. So a few answers to the title, The Bridges to Nowhere, the Abandoned Tracks and the Sinkholes. Well, in my mind, the bridges to nowhere are data silos with little to no interoperabilities. The abandoned tracks are the multiple competing data standards and specifications. And the sinkholes are data ownership claims, impeding integration, interoperability, and innovation and standardization across the industry. One thing I will note about standards is I find it a very confusing landscape. And you can see here in this comic that many people, including some of us on this webinar today, probably have had the idea we need a better data standard to rule them all. And then what happens is we add one more to the long list of data standards that are out there. And this happens not just in the diabetes or NIDDK space, but also, as you can see at the top, in things like instant messaging, character encoding, and AC chargers. So one of the problems that we have is that the data types and sources in diabetes and metabolic disease care themselves are quite diverse. And in addition, they can be used across the spectrum of the disease journey, from screening and prevention to diagnosis, prognosis, and then treatment and management. Another issue is that healthcare data have a lot of complexity to them. So if we think about the data we encounter in electronic health record systems and ancillary systems in a healthcare institution in North America, we have both structured and unstructured data. The data may live in multiple software platforms. Not all data are housed in the electronic health record. And in a world where care is becoming increasingly remote and driven by ancillary devices to support self-care of a disease, some of the data is housed in proprietary software platforms by third-party vendors. Data definitions can be subjective and they change based on the source. Not all of the manufacturers or electronic health record system are using all of the same standards. The format of the data, so is it a JSON message? Is it another kind of data packet? Change. The data complexity changes because we're dealing with human beings after all. And we have to operate within the constraints of regulations and design requirements that often come from our regulatory agencies. When we think about device data, which are so prevalent in diabetes care, we have first the raw signal that comes from a sensor or a measurement device, and then we have the processed signal, and then we have features that can be derived from the processed signal, and we have metadata. And all of these data may be relevant for capture by research institutions and healthcare institutions during the course of care and clinical research. So what is the problem? Where are the bridges to nowhere? Well, one of the problems we have is first, while we have an increasing prevalence of really innovative devices, including continuous glucose monitors and insulin delivery devices that record insulin doses, consumer wearables that can measure physical activity, and beyond, not all of our patients and research participants have access to all of these. Sometimes they're cost prohibitive for a research study. Sometimes they're cost prohibitive for the individual. And in addition, when they get the device, they may also have issues with sharing the signal to the cloud. So a common experience of individuals with diabetes is that they're wearing a CGM and they have intermittent interruptions in the Bluetooth signal, such that they lose connectivity to the receiver, whether that's an insulin pump, a phone, or a dedicated receiver. And then once the data are in the cloud, they can be shared, of course, with the manufacturer portal, which is usually the first user interface for them. But then if another entity like a healthcare institution would like to bring those into the electronic health record or bring them in some other way into the healthcare ecosystem, you have complexities related to the type of message, the need to clean and deduplicate to manage identity in the data and link to identity in the electronic health record. And then you have issues related to, are you sending the data directly into the electronic health record? Does your institution have the resources to make those connections and communications? Or are you bringing it into some sort of enterprise data warehouse that can communicate with the electronic health record? And then do you have the resources to create the user interfaces to interact with those data? And ultimately, what we want, is for the individual with diabetes or metabolic disease to have access to these data collection tools, and we want the providers to have access to the insights and knowledge that can be derived from them. So some of the gaps that we see relate to data ownership and rights. And the concepts of data ownership and rights vary depending on where you are in the world. But in the US, while patients generally have access to their health data, they typically don't own the data in the same way that they might own a physical item. So hospitals and manufacturers often hold the data, and the data contracts between organizations in the ecosystem play a crucial role in defining who owns and controls the data. There's a lot of risk mitigation that goes into contracting. There are also concerns related to privacy obligations and regulatory obligations that can simply lengthen the timeline for contracting. There are multiple competing data standards. I don't have an exhaustive list here, but just a few that I'm well familiar with, and specifications. And one has to choose where one is mapping the data to. Multiple competing data structures and access methods. So again, are you getting the data as JSON packets or as some other type of packet? Is it a push or pull through an API? And are there adequate technical resources at the healthcare and research institutions to make all of this happen? And designing data interoperability is complex. So for organizations outside of a healthcare institution, quite often there's not significant motivation in their business plans for designing this interoperability. And so the burden is left to the healthcare institutions to try to figure out how to bring data external to the healthcare institution inside, in particular related to CGM and other device data. And you can see this is a very complex process that requires identification of needs, creating the list of requirements or standardizing the artifacts that one wants to create, and then going through the co-creation, governance, and alignment that allows implementation of interoperability. And another way to look at this came from Juan Espinosa and colleagues. You can see 8 steps here, from identifying needs and doing the discovery work to the solution identification to the implementation and then the evaluation, which is really the quality improvement life cycle applied to data interoperability. So, the pace of innovation in diabetes care is increasing, but it's still difficult to visualize the real costs that data silos and lack of standards create for both healthcare delivery and for innovation and research. And I would argue that the cost of data silos and lack of standardization is quite significant, and that we have both ethical and fiduciary obligations as we are stewards of research and healthcare dollars to design interoperable data ecosystems that ultimately support the creation of true learning health opportunities. So what becomes possible with true data interoperability after solving for data standards? One is clinical decision support systems for diabetes and metabolic disease. You can see an example of a clinical decision support tool on the left. So this is an algorithm related to the use and progression of use of glucose-lowering medications in type 2 diabetes. And there are a number of entities that have turned that into clinical decision support systems, which are digitized, I would say, computer-augmented intelligence versions of clinical decision support to aid human beings in making decisions. Another example of what becomes possible are population health management dashboards. What I'm showing you here is an example of what's called the TIDE platform, which was created by the Stanford SURF team in collaboration with their Pediatric Diabetes Center. And this system actually has a lot of intelligence behind it that rank orders and sorts patients by a number of different risk biomarkers, all derived from continuous glucose monitoring data. You can see percent time worn, the average glucose, the percent time in range, and then in the green and red on the fourth column over the percent change in time in range in the last week and so forth. So this is a way that you can drive risk-based population health management processes in clinic. But of course, it depends on getting the CGM data from the device manufacturer platforms into the healthcare institution's ecosystem. And then, of course, multi-institutional learning health networks like the T1D Exchange Quality Improvement Collaborative are powered by data, they're powered by decision support and population health strategies. And again, the goal here is to try to lift up the care at not just one institution, but across many institutions using common principles. And this also relies on the creation of a data standard and data interoperability. I was privileged back in 2016 to actually serve along with several colleagues as one of the data science co-leads and wrote the data specification for this particular quality improvement collaborative. So what becomes possible with true data interoperability for persons with diabetes or metabolic disease? I'll show you just one example, and it's one that I found very compelling. As we think about how we can help individuals with diabetes or metabolic disease in their daily lives when they walk out of our clinics and go home, the concept of the just-in-time adaptive intervention is really a technology that relies on psychological theory-driven interventions and the advent of mobile applications through mobile phones. So you put these two together, and all of a sudden you can think about using sensors to understand states of vulnerability or opportunity, as well as states of receptivity in an individual, such that if you were to try to nudge them with a text message, a push notification, a meme, a GIF, I don't know all the Instagram terms these days, but you would be able to know what are the ideal times of day and moments in their journey with diabetes or metabolic disease in which to send the nudge. And if you add a form of AI, a reinforcement learning engine that is playing a game that is trying to understand which types of nudges, which forms of a nudge, and at which moments of the day a nudge can be most effective at causing a person, for instance, to get up out of their chair and go take a 10-minute walk, or to remember to take their insulin dose with a meal, or to remember to take their medication, or perform a mindfulness exercise to reduce their level of distress. You can see how this could really be quite powerful in carrying the care that we provide outside of clinic and into their daily lives. Of course, with permission and transparency from the individual. And then I would say that one of the reasons I feel so compelled by this new technology and the capabilities that can be generated from having good, solid data standards and interoperability is that we know this already works. Any of us who are on social media every day should recognize that this is exactly the game that social media is playing with us to try to drive our attention to click more and to spend more time on screen. So it's really quite compelling, and it originally comes from the fields of advertising and marketing. So why do these innovations that I'm talking about matter? These innovations matter because there are not enough specialists to manage endocrine and diabetes conditions and other metabolic diseases. You can see on the left the distribution of US counties with an endocrinologist or diabetologist, one or more, and you can see the percent of counties with one or more primary care providers. Not only are our numbers scarce, but our numbers in pediatric endocrinology are actually declining. So, here's what the crisis looks like for pediatric endocrinology, and you can see that there are quite a few places around the country where there are 1/2 to one entire pediatric endocrinologist per 100,000 children. And it just doesn't make for sustainable care when you think about the prevalence of endocrine, metabolic, and diabetes conditions among children. The other reason that these innovations are important is that diabetes self-management is complex. The demands are unrelenting. You can see on the left the 7 pillars of diabetes self-management as listed by the ADCES organization, formerly the AADE. And one can map these pillars of self-management to various, again, psychological theory-driven interventional strategies to see if you can help an individual become more successful at engaging with any one of those pillars of self-management. And again, my psychology colleagues who are much smarter than I have filled an entire body of literature with evidence that either supports or refutes the role of particular strategies and their supportive theories in any one of the particular behaviors we're talking about on the left. So the last thing I'm going to share is about how we in our hospital system and our research program called the Rising Tide Alliance have created a data-driven diabetes care transformation initiative that is powered by predictive analytics and risk-based population health management strategies. And I'm going to show you how we have actually brought the data in to drive all of this, and how we relied on a robust data standard that helped us accomplish our needs. Not the most mature data standard, but at least a robust data standard. And ultimately, what we're trying to achieve in that initiative is a smart system where we have enhanced data collection in the due course of clinical care. We can perform near real-time data listening. We can forecast outcomes. We can risk stratify patients, and then we can match them to a library of behavioral device, drug, and other care delivery interventions that really will help support them at that particular moment in their journey. We started with the premise that our population, if you take hospital admission for diabetic ketoacidosis, for instance, as an outcome we're trying to avoid, and you could put any outcome in there. Our population has diverse risk for any given outcome and diverse responsiveness to any intervention we could put in front of them. And if we're able to take all of the available biomarkers and data that we can bring into the healthcare ecosystem, we could risk stratify individuals, and then we can target behavioral and care delivery interventions that you can see on the right I've operationalized as wraparound services for the drugs, biologics, and devices that we prescribe to help everybody be more successful on those primary therapies. Some people may only need a CGM prescription and they will do very well, or an automated insulin delivery system prescription and they will do very well. But I can tell you, from my experience treating teenagers with diabetes, there are still quite a high proportion who don't achieve the outcomes that they desire or that we desire for them on those therapies, and they need extra help. So what have we done? So we created something that we call the D-Data Doc, or the Diabetes Data Doc. You can see on the left that it's pulling data in from a variety of sources, both internal and external to the healthcare organization. including consumer wearables, including CGMs, blood glucose meters, insulin delivery devices. We're bringing the data into a data lake, and then we undergo processes of data cleansing, deduplication, conflict resolution, and these are very complicated processes. And then we create derived variables and transform and standardize the data. And we have selected the T1D Exchange Quality Improvement Collaborative data specification for our purposes. There are more thorough and sophisticated data models and standards out there, but this one was going to suffice for the work that we wanted to do over a span of about 5 years. We are now working with Juan Espinosa and team at Lurie Children's to create the ability to laterally translate data across data standards. For instance, so that we could translate from the T1D Exchange spec to OMOP and vice versa. And you can see that once we create a standardized operational data layer, we can add all these complex mathematical functions like advanced predictive analytics. We can create run charts and dashboards to visualize our care. We can even perform synthetic clinical trials using propensity score matched cohorts in this DDataDoc. Just a couple of examples. We had a paper published in January in Diabetes Technology and Therapeutics on forecasting and ranking risk for hospitalization for diabetic ketoacidosis. And we created what we consider to be a clinic-to-clinic transferable machine learning model to accomplish this. I'm not going to go through the data in detail because we've got a lot of other speakers today. But this model performs very well. You can see the precision tends to be above 60%. Again, this is for a rare event that is occurring in our center at about 2.5% of the population in any 6-month period. And we've got precision up to 60% here. We're getting significant lift in the middle curve. You can see the amount of enrichment is like 16 to 18-fold. And we can even claim explainable AI because we're using Shapley values to help us gain insight into which features are driving it. And some of these are modifiable risk factors that we can focus interventions on. Again, I told you we started with the T1D Exchange Quality Improvement Collaborative Data Standard for this, so you can see that highlighted in the center. There were about 9 months of discussions here to get to this point. Why did we use that? Because there are 62 centers that are using this standard to map their data, and we can disseminate a model like this to those 62 centers. We've also created models to forecast hemoglobin A1C over the next 90 days. Again, I won't go through the details here. We've created a new scalable model to forecast time and range over the next 14 days that we think will be an advantage to the TIDE platform from Stanford that I showed you earlier. Again, you can see some of the risk factors that are most highly weighted in our model. And we had to go through a lot of data mapping and creation of derived features from the CGM data for this prediction so that we could test. Not only did we take data from CGM, but we mapped a lot of data from the Type 1 Diabetes Exchange Data Specification from our EHR, as well as clinical observations, so both demographic and clinical observations. And then, there are innovations in care based on non-predicted biomarkers that we're using. My colleagues Joyce Lee and Sarah Carruthers published on the 6 habits of diabetes care. We have tested these 6 habits using our EHR data and the habits. The more habits one engages with at any particular clinic visit, the lower their A1C appears to be. We've been able to identify a 7th habit from our clinical documentation related to consumption of fruits and vegetables. And we're now able to cohort intervention samples and say, well, what do their habit scores look like? And are we moving the needle on habit scores, which we believe will be a driver ultimately of A1C? And then finally, I mentioned to you the population health management platform called TIDE from the Stanford SURF team. They've gotten great results from this in the first year after type 1 diabetes diagnosis. They've reduced A1C at 1 year post-diagnosis by over 1%. which I think is very significant, by integrating CGM data, by using that to drive remote healthcare delivery. And we've added a feature called the mealtime insulin bolus score to that at our own center and are testing that in the risk rank ordering. And we're actually driving an NIH-funded intervention that uses behavioral economics to drive mealtime insulin bolus behavior among teenagers. So we have a whole process that begins with data integration, leverages a team that identifies people at risk and then matches those people at risk to various behavioral and care delivery interventions. We call that the Rising Tide Alliance approach. And the goal is really to create a whole new kind of ecosystem for care in a diabetes clinic, and one that can allow a lot of innovation to be created during the due course of clinical care. So in conclusion, lack of data interoperability and standards is very costly. Designing for interoperability can save healthcare dollars, can accelerate research, and can accelerate the pace of innovation. These are the folks on my team that I need to thank. And here's where you can learn more about the Rising Tide Alliance. And I thank you.
Well, thank you very much, Mark, for this very, very informative presentation. We will have the opportunity for questions at the end of session 1. So now we are going to go directly to session 1. And session 1 is about stories of data collection, integration, and interoperability. The first speaker is Juan Carlos Espinosa. I have a great pleasure of introducing him. He's the Chief Research Informatics Officer at Lurie Children's Hospital, and he's also Associate Director of the Center for Biomedical Informatics and Data Science at Northwestern University. He is also the director and principal investigator of the Consortium for Technology and Innovation in Pediatrics, which is funded by the FDA. His research focuses on identifying, refining, and innovating approaches to using data, media, and technology to improve health outcomes and reduce health gaps in the US and abroad. It's important to mention that his work on diabetes device data and data integration standards is rooted in collaboration with industry, regulatory agencies, researchers, and healthcare organizations. So please go ahead, Juan, with your, he's gonna tell us about the tale of two standards, ICODE and the Diabetes Research Hub. Welcome, Juan Carlos.
Wonderful. Thank you so much for the introduction, Guillermo, and thank you to the NIDDK and to the organizers for the opportunity to speak today. I'm gonna go ahead and start can you all see my slides in full screen?
Yes.
Perfect. All right. So I will try to be brief, but today I'm going to talk to you about both ICODE and the Diabetes Research Hub, two different approaches to standardizing diabetes-related data. These are my disclosures. Mark and I, who are frequent collaborators, have complementary disclosures. He says he's not an informaticist. I say I'm not an endocrinologist. So apologies if I say anything wrong about diabetes as a disease. But I am a pediatrician and informaticist that really loves this field and has spent the last decade or so working in it. So I'm going to give a brief overview of the CGM data ecosystem. I'll be brief because I think this is an audience who is very familiar with it. I'm going to talk about ICODE. Then we'll talk about the Diabetes Research Hub, and I'll finish off with some thoughts on what I think is next for the field. So a brief overview of CGMs. So they seem to us ubiquitous now, but it's important to remember that we've really only had this technology for 25 years, from the first approval of the MiniMed CGM in 1999, and really didn't see a lot of broad adoption really until the last decade. What you can see from this chart of the four main manufacturers that have approved technologies in the United States is these gaps in early development, and then more recently in the last decade, really more frequent product releases that have more data, more features, always intended to be more user-friendly for both the people with diabetes wearing them, but also for the clinicians taking care of those people. CGMs have been studied extensively. We know that they improve glycemic control, they improve time and range, they're associated with some cost savings, increased self-efficacy, they improve sleep quality, quality of life. It is worth, however, calling out that these benefits they're not experienced equally by all populations. For some, they can actually increase this concept of learned helplessness. And it is critical that we provide support, we as clinicians provide support to those patients who are using these technologies. That said, it took years to get there. They weren't a success overnight. Data workflows were really burdensome. The data portals came much later for all of these platforms. The CareLink wasn't introduced until 2010. The LibreView wasn't introduced until 2015, and Dexcom Clarity wasn't introduced until 2016. So for years, the only way to review this data was by manually downloading it and looking at files for individual patients. So it took making that data more visible, more available for us to really be able to derive all of the benefits from these technologies. Interpretation evolved slowly. The AGP consensus meeting that was funded and supported by Helmsley and led by the IDC didn't happen until 2012. The consensus metrics, the ATTD consensus metrics were from 2017, and the ADA didn't include CGMs in their practice guidelines until 2021. And we didn't have coverage, which is a critical component of this, really until 2017. So all of these pieces had to come together to get CGMs to where they are today. And that ecosystem, it's important to remember that how many players are involved, because whenever we think about data standardization and data interoperability, it's not just manufacturer to EHR, it's not just research standards. There are so many different organizations and types of players. So from the manufacturers who actually make the devices and provide the true source of data, to the aggregators and integrators that help bring all that data together into common platforms, or bring that data into EHRs and other systems of record, to the professional societies that set the guidelines for how we use this data in clinical care, to the patient advocacy organizations and funders and support organizations that really demand better of us, those who are helping to develop the technology, help develop the standards, so that we really meet the needs of people with diabetes, to all of the digital health and health management platforms that leverage this data in order to provide comprehensive wraparound support to people with diabetes, and then of course all of the major research centers who help drive this technology and the use of this data in this first place. So I just want to call out that this is not an exhaustive list. It is not intended to leave anyone out, but really meant to be representative of the ecosystem. So that said, let's talk about ICO. And it's important to think about, why do we care about this concept of bringing CGM data into the EHR? And fundamentally, the EHR is where we as clinicians, it's where we work. It's where we have to do our documentation, where we do our billing, our chart review, and our order entry. And anything that takes clinical workflows out of the EHR introduces some additional cognitive burden, and introduces the opportunity for errors, and it takes more time. And with the physician burnout crisis, none of those things help. So we have to think about meaningful ways to bring the data we need to care for our patients into the EHR. But our current state is a classic interoperability problem, right? Our patients, they live in these data-rich ecosystems, but the only thing we get is what we can talk to them about in a visit and what's captured in the EHR. It's a classic, sort of this in the traditional levels of interoperability diagram that you see there on the left. We're sort of still at that level one. Like, we're just not really getting the information we need. At most places where we take care of patients with diabetes today, if the CGM data is going to make it into the EHR, it follows the workflow that you see on the top. The data gets uploaded onto the manufacturer's platform, the staff then logs into the platform, they print out that report, they hand the report to the clinician maybe reviews it, signs off on it if they need to, then they send that report to medical records or HIM, and it gets scanned into the record. in 2 to 3 weeks. Or they might upload a PDF depending on the EHR that they have. And really what we want to get to is the workflow you see at the bottom, where the patient is uploading their data. A person logs into the EHR and they essentially either already have the data because it's being pushed in, or they order the data, and then it's just there. It's available in view and in line and with context of everything else. So you have their labs and their vitals and their clinical history and their CGM data all in one place. There's a number of technical integration barriers that prevent that today, from how you get the data source to how you do the account linkage to how you might exchange the data, where you're going to store it, how do you display it, and what is the appropriate governance for those kinds of workflows. This work for CGM EHR integration has been happening for about a decade now. I'd say the first big advance in this was a project done at Stanford, led by Rajiv Kumar, where in 2015 and then published in 2016, they built an integration that worked very well. Using the Dexcom Share app to the Apple Health Kit to the Epic MyChart app and into Epic. It was a little bit complicated. We might describe it today as a Rube Goldberg machine, but at the time was really the only way to do this. It was really innovative. It was impressive that it worked. And it kind of set off this cascade of other people trying to figure out how to do this work. Shortly after that project, Dexcom had reached out to my team at CHLA, and then we worked on building, instead of working through the various mobile platforms, we tried to set out, can we just do a cloud-to-cloud exchange? And we leveraged HL7 data exchange standards and built and then published on essentially the first cloud-to-cloud CGM EHR integration. Since then, there's been a number of partnerships and work happening with Abbott and Medtronic and Glooko and Tidepool to advance this work. In 2020, the Diabetes Technology Society published their CGM in the Hospital consensus that addressed some of these issues about bringing CGM data into the EHR. In that same year, Abbott collaborated with IDC to integrate Abbott data into their Epic EHR in a nice structured way that I think was influential for other organizations looking to do data integration. And all of that milieu sort of inspired the development of iCode. It's this idea that every time an organization wanted to do these types of integrations, they needed to start from scratch. And there had been enough learning that we felt it was important to set that out as a standardized, consistent way to bring CGM data into the EHR that required certain expectations from both the manufacturers and the healthcare systems. And so all of the planning for iCode happened in 2021. In 2022, the standards were published. And in 2023, we started working on iCode 2, which is going through the same process, but for insulin devices. And I can say some of the things that are exciting is that in 2024, per the iCode recommendations, Dexcom was the first CGM manufacturer to launch a Fire EHR integration that follows the iCode standards. Abbott launched theirs a few months ago. And then the Argonaut FireWrite project, importantly, worked to take the iCode standards as a baseline and write FHIR standards for how to bring this data in. So there's been a ton of work to really make this possible. So let me tell you a little bit about iCode in detail. So iCode stands for the integration of continuous glucose monitor data into the electronic health record. That is a mouthful, so I'll keep saying iCode. The goal of iCode was to develop the technical specifications to integrate CGM data into the EHR, but just as importantly, if not more so, is to develop the workflows and guidelines to facilitate that data integration. If we just released technical documentation with no guidance to how to make it possible, we knew we were going to fail. And then, of course, as Mark mentioned in his talk, how to avoid doing this. We don't want a proliferation of standards. And that's important in this work, right? Because there's actually already lots of standards and best practices that can be used. If you think of the data pipeline from patient to physician, there are these 5 types of events, whether it's security or data models or identity or messaging exchange or terminologies. then there's actually already lots and lots and lots of standards. And we shouldn't be adding to the list. We should be coordinating what are the best approaches at each of these steps in order to achieve the goal of better data interoperability that ultimately helps us take care of patients better. So iCode was divided into 6 different working groups, which were, 3 of them focused on really the technical piece, and 3 of them focused on the operational pieces. How do we do best practices and common frameworks? We had over 130 participants from 60 organizations across every sector, industry, academia, government, healthcare organizations, providers, patients, all participated in this process. One of the things that came out of it is we developed our adapted interoperability framework for CGM data. So we took the sort of the traditional 4-level interoperability model and turned it into the 7-level model that applies specifically to how CGM data, from transcription, which is sort of that there is no interoperability, that is a clinician sort of opening up a CGM platform in one screen and their EHR on the other screen and essentially transcribing it, a human API, if you will, or what sometimes we call a swivel chair integration, all the way to having discrete data that empowers advanced analytics using machine learning to develop risk stratification and everything in between. Because I think that gets this level of granular maturity discrimination between these levels really helps organizations understand what to target and how with different technology approaches. So in the iCode report, we established definition of device data classes, and we created these core data sets and expanded data sets to help guide manufacturers and healthcare organizations to figure out where do they want to start in terms of what data to bring in. We also worked with the Regenstrief Institute when we had LOINC codes created for all of the core data set elements so that we can leverage standardized terminologies as well. We also identified existing data schemas where CGM data might already be integrated, can be integrated, and then how to integrate it. So whether it was in OMOP or I2B2 or PCORNet or Sentinel. We also identified the other schema from IEEE and ISO that were relevant to it and provided guidance to users on how to incorporate those existing schemas into their data work. Our clinical workflow teams really did an amazing job in terms of providing guidance, down to the 5-minute interval of how to think about these data integration workflows in terms of a clinic visit. And what are the different kinds of responsibilities? Is it the clinical staff? Is it the clinician? Is it the patient? Who's doing what in ways to make it possible? So we knew it's hard to start from scratch. And so we figured that if we could provide a framework, then each organization can then tailor that framework to their own clinical workflows, to their staffing model, to their scheduling model. But at least it gives everybody a common starting ground to make this possible. Sustainability is critical, so we provided guidance on available CPT codes and reimbursement, as well as modeling, what kind of visits might generate certain kinds of revenue based on billable rates from different models. David Schenker's group at Stanford from the SURF team, they've also published a really useful RPM calculator that we reference and recommend that people use. We developed a digital health integration framework to help organizations think through what are all the steps that they need to go through in order to bring these technologies in-house, with everything from understanding patients' ability to access those technologies through their security, financial, operational, and business capacity to do this, and focusing, of course, on training for everyone, patients, providers, their staff. And so the final report is just over 100 pages. It's divided into 3 main sections, kind of an introduction and overview, the technical standards, the clinical implementation. It also includes a project implementation guide and these 54 recommendation statements, which are really a set of philosophies that should guide all of this type of work at any given organization. We also had a pretty extensive appendix of references and resources. Since it's been published, it's been endorsed by professional societies. It's been downloaded about 500 times by 300 different organizations and has influenced the way that many of the CGM manufacturers are making their data available for integration. And of course, it's free and available on the Diabetes Technology Society website. So changing over to a new topic as a different story that I want to tell you about data standardization is the Diabetes Research Hub. So for many of you, and Mark alluded to this already, know that there are some, we think of CGMs as being relatively straightforward, right? It provides the output of a CGM is a timestamp with a glucose value. But there's actually quite a lot of barriers to meaningfully doing research at scale with CGM data. There are technology barriers, right? There are proprietary data platforms. You can have complex data workflows. How do you access the data in the first place? Where do you bring it into? There's not a lot of CGM specific tools built specific to manage CGM data. There's a lot of knowledge barriers. There's lack of methodological consensus. People, even things that like concepts that we think of as fairly universal, like time and range, there's a lot of disagreement of how do you calculate time and range, and depending on the situation and the intended purpose of the analysis. So there's a lot of gaps in our methods, in how we educate folks, how we provide guidance to them. Manuscripts report their methods inconsistently, so it's hard to then learn from the literature. And from a community perspective, we don't really have a central hub for CGM research. There's really kind of ineffective data sharing and reuse. Mark alluded to this in his sinkholes analogy. And again, these siloed research groups across fields. And if you look at current resources, whether they're funded by an NIDDK or generally supported by the NIH or the general repositories, they really don't have CGM specific support systems. They often don't have time series analysis other than PhysioNet, nor do they report on or have metadata on glycemic variability metrics. Two really useful tools that are out there are the Digital Biomarkers Development Project run by Jessie Lynn Dunn, which is not necessarily a data repository, but they have a ton of code that they've released and published focused to analyze CGM data. It's really fantastic. If you're not familiar with it, I encourage you to check it out. And then Awesome CGM, which is it's a GitHub project. It's a group of researchers who got together and said, wow, there are no great places to find CGM data. So they essentially put together links of existing CGM data sets that have been published and some R code to help people learn how to analyze CGM data. So from that background, a group of us from the Diabetes Technology Society and NetSpective Foundation and through a number of different organizations created something what we call the Diabetes Research Hub, which is really intended to address these barriers. It's one place to both deposit data, to work with other researchers, to find data, and to learn how to manage and use CGM data. And so far to date, we've had 10 studies deposited in there that cover slightly more than 1,200 different participants. About a little bit more than half of them are female, and over 43 million data points of CGM data. And so our approach is starting from the foundations, right? We create the guidance and education for methods for data management and analysis. We are building the free tools, free open source software tools to clean, transform, manage, and analyze CGM data. We've built a repository that has dynamic storage and display capabilities. So in real time, you can evaluate the content of any given CGM file to see if it meets your needs. And then working on building a community of collaborators and peers and mentors who can work together and share best practices. And we feel that these four elements are foundational to help drive scientific and clinical breakthroughs in the field. To enable this, we've developed a data model for the Diabetes Research Hub that is inspired by the Odyssey's OMOP model, which is a tabular-based model that allows you to populate a significant amount of metadata about any given study, including the participant it came from, the study that was conducted, the investigators, the research group, the institution, any publications related to that. Today, the DRH as a tool, which is live and operational, and you can visit it online, starts with a web portal that we've built, and there are some links to resources, papers, and podcasts, and other websites. You can do data exploration. You can see what's in those 10 studies that we are currently hosting, and you're able to then do some basic visualizations. We calculate about 30 different CGM metrics, again, in real time across any user-defined time period. You can actually create what we call synthetic cohorts. So you can bring participants together from different studies because they meet your criteria based on CGM data. And then you can download that data that's available. You can also upload and deposit your own studies data if you have the appropriate clearance from your IRB to do so. We've also built what we call DRH Edge, which is a local software that essentially does everything our cloud version does, so that if you still are working with data that contains personal identifiers, but you are still in the data processing, data cleaning, and data analysis phase, you can actually download our software. It's free and open source, and use it to clean and analyze all of your data. It also has the advantage that it's then already formatted so that you can upload it into the Diabetes Research Hub. So again, just trying as much as we can to solve problems for the community. In the future, our goal is to expand the DRH to really create an entire resource library, host webinars, build forums, listservs, and newsletters, gather members of the community to develop consensus guidelines, and make the actual technology even more robust, build a curation pipeline where we're doing normalization and harmonization of the data, connecting to the UMLS terminology services to making sure that everything maps to known vocabularies, and then building
1 minute remaining.
And then building out APIs to connect with other repositories, working with CGM manufacturers to leverage this technology to help extract data. And then, of course, in the state where we are today, where the field is, where AI is accelerating so rapidly, deploying a model context protocol, which is an emerging standard for how different agentic AI tools can interact with data sets, to make that a possibility for our community. We've developed we plan to deploy a really powerful data curation process and a tech stack that conforms with best practices. I'll leave you with this, which is, today I think what's worked well for us is this concept of adopt, adapt, create, right? If something works, use it. If you need to change it a little bit, fine. And then only create if those first two things don't work. Being hyper collaborative and open is important, and being patient, because all of this process takes a while. What's been hard is that standards work is rarely attractive to funders. So we often bootstrap a lot of these efforts, and that it's compromised by definition because they need to work for everyone. So there's quite a bit of work that still needs to be doing. There's policy changes to device data accessibility that needs to happen. There's actually an open period comments that are due June 16th to a request from HHS on technology ecosystems that I encourage everybody here to look at. We need to develop CDEs for diabetes technology, and we need to figure out common shareable standards for moving tabular data to time series data models, because that's where the field is going. And then formalizing device metadata standards, including our reporting structure. So with that, thank you very much. I really appreciate your time. If you have a moment, I would appreciate your feedback on my talk and my slides today. Happy to share my slides with anyone. And I'll put links to iCode and the Diabetes Research Hub in the chat. Thank you, everyone. I really appreciate it.
Okay, well, thank you, Juan Carlos, for this great presentation. It's amazing to see how much you and your team have been able to achieve in just the last few years in this space. Well, it is great. So we will have more time for discussion at the end of the session. Well, we'll see now. The next one is from the NIH. It's going to be Chandan Sastry. Chandan currently serves as the Deputy Chief Data Officer for the All of Us research program. In his role, he's focused on supporting data strategy, analytics, and data governance. Prior to joining the All of Us team, he worked also as the CIO and senior advisor as a CIO and senior advisor for the AI operations of the National Institute of Standards and Technology. Also, he has experience at the NIH, serving as the director of the Clinical Trials Database for the NICHD, CIO at the NIDDK, and the director of the Clinical Research Informatics within the Office of Intramural Research. And he will tell us about the integration and standards for the All of Us data types. So please, Chandan, go ahead with your presentation.
Thank you kindly for the introduction and opportunity to be here today. It's a pleasure to present the All of Us research project and highlight some of the challenges and opportunities that we can collaborate on to improve data standards for research. Next slide, please. So the All of Us research program is part of a national strategy to make precision medicine a reality for everyone. Our mission is to accelerate health research, enable individualized prevention and treatment and care. And we've got three key goals. The first is to nurture partnerships with over 1 million participants. The second is to deliver one of the largest and richest biomedical data sets. And the third is to catalyze an ecosystem of communities and researchers. And it's really this that brings me here today. Next slide, please. So the All of Us projects collects a wide range of different data types. And our data and research center at Vanderbilt University assists us in collecting and curating all the data collected from participants and healthcare providers into a large-scale database. We then make the data accessible to thousands of researchers over a secure cloud platform, and we offer 3 tiers of data access: a public, a registered, and a controlled tier. Next slide, please. So over the last 7 years, the All of Us program has enrolled over 800,000 participants and collected an enormous amount of data and organized that for researchers. Some of the key data types include survey responses, physical measurements, electronic health records, wearables, genomics, biospecimens. So the project also has become an important platform for trans-NIH initiatives and collaboration. The Partnered Research Studies program allows groups to leverage this engaged participant base and conduct follow-on studies. And the Nutrition for Precision Health NPH study, which I'll talk about later on, is a real good example of this. Today, we're going to focus on 4 of these data types, which I've highlighted: surveys, electronic health records, wearables, and the NPH study, because I think these might be of more interest to the NIDDK community. Next slide, please. So the first, electronic health records. So about 400,000 of the All of Us participants consented to share EHR records. And the program adopted the OMOP Common Data Model as a unifying standard. So a playbook was developed and utilized by HPO partners to map and transform participant records from source systems, including Epic, Cerner, Allscripts, Athena, and where feasible, HL7 Fire was leveraged to facilitate transfer. And the resulting data set is impressive. Many of the records date back up to 40 years, enabling retrospective longitudinal cohort analysis studies. So while OMOP has many benefits, such as improved data interoperability, large-scale analysis, there are some significant concerns and challenges. We see data loss when mapping EHR data to the OMOP model. We also find inconsistencies and variances between sites. And there's a lack of text data coming from clinical notes, which would be really nice to have. So some of the recommendations and opportunities we have are really to work collaboratively with the other some other NIH efforts that are underway. ODSS has a data counts initiative. There's the N3C initiative to leverage national platforms that are underway and to develop methods to collect participant data outside of HPOs. Next slide, please. So digital health technologies and wearables is another data type. Up to note here, 30% of Americans regularly use a wearable device. And this data type really represents, I think, a great opportunity to collect more personalized data and real-time metrics. So our current release is limited to Fitbit devices and includes data on steps, heart rate, physical activity, sleep, and our plan is to expand to other device types. And some of those potential devices include smartwatches, fitness devices, metabolic tracking, and possibly even smart rings. So some of the standards in this area that we're working on, utilizing FHIR to transfer records, but also best practices to capture data provenance, policies for security and privacy. The resulting data set that we have has become a valuable resource for studying behavior and lifestyle and its impacts on health. However, there are lots of challenges here. Areas that need consideration include data ownership, patient trust, interoperability, and of course the integration of these data into clinical care. So our Fitbit data was organized into separate BigQuery tables on our Google platform, and it's not necessarily harmonized with the OMOP CDM. So the data set will require custom analysis due to this sort of lack of integration. So there's some real great opportunities to improve. It would be nice to develop computational algorithms and standard metrics, and to collaborate with industry and HHS groups to leverage some of the data models and programs to help merge this data across multiple devices. Next slide, please. So this graphic here kind of shows some of the benefits of, I think one of the key benefits of the All of Us research program, and that's the ability to overlap the data types with existing participants. And so, for example, we have 60,000 participants with Fitbit data, and you can see in this table the overlap with EHR and other data types. And so the All of Us, this partnered research study program, this mechanism, I think, is a great opportunity to build collaborations. Next slide, please. So the Nutrition for Precision Health, or NPH study, is a great example of this. With about 8 different institutes and centers at NIH collaborating and leveraging the All of Us program. The goal here is to develop algorithms to predict individual responses for foods and dietary patterns. And so the NPH will incorporate a wide range of different data types: genetics, gut microbes, lifestyle data, biological, environmental, and social factor data. And the objective is to develop individualized eating recommendations that will improve health. And there's three modules to the program. The first is sort of a cross-sectional study, and then it starts to become, in module 2 and 3, more controlled settings. So the NPH study will leverage existing standards for data collection, including the ASA 24 and other dietary assessment tools. One gap, not only in this study, but we see in others, is the ability to merge data from multiple vendors. I think, as you heard from our last speakers, NPH is using Dexcom 6, but we know, other devices, as we expand to other devices, merging those, particularly the Freestyle Libre, has become quite popular. You know, it would be nice to collaborate with industry and HHS groups and develop and implement and leverage some of the projects that we just heard within the All of Us project. So I think this could be an area of discussion. Next slide, please. So last data type of interest, and these kind of come for free when you get All of Us, is the surveys. You know, All of Us utilizes a range of validated instruments and common data elements to standardize and collect some high quality data from participants, and allows researchers to understand genetic, environmental, and lifestyle factors that influence health. And of course, the focus for us is on making healthcare more personalized and more equitable. The use of these well-established instruments kind of helps with reliability and validity across this sort of very large, diverse cohort. But some of the challenges we see in this area are really response bias and sampling bias, particularly sampling bias. You know, the All of Us project actively recruited those who are underrepresented groups, and so the demographics are not readily generalizable to the broader U.S. population. However, to address this issue, one of the things we're doing is developing statistical weighting tools and methods to improve generalizability. Next slide, please. So just some next steps. You know, biomedical research, I think we heard today, it's challenging from a data perspective. You know, we face technical challenges, operational challenges, and strategic challenges. And the All of Us project, the data set, the infrastructure, the computing platform that's available, and more importantly, that engaged participant base. I think that represents a nice opportunity for us to work together to improve standards and improve research. And some areas to consider, you know, first, to accelerate research impact, you know, improving the linkage methods for multimodal analysis, bringing all these different types, wearables, genetics, lifestyle, and environment together, defining standard phenotypes. So this on the research, we talk about standards for data collection, but also in terms of research output and metrics. You know, it'd be great to get the domain experts that NIDDK has to help define some of these metrics for usage across multiple projects. And then, of course, you know, of great interest to us is this integration of CGM into the EHR data sets, and working with HHS partners to sort of bridge wearable data into the clinical record a little bit easier. And then lastly, I'll throw out, as we move to discussion, is to consider the concept of reference standards and the calibration of devices in research studies. I liken it to back in my days and doing chemistry work at the bench, is developing a standard curve with calibration curve with reference standards. If there's a way we can do that and figure out a way, it's not necessarily that we need to develop a new standard, but we just need to have corrective factors to bring data from different vendors together using sort of reference standards. So next slide, please. I just want to say that the All of Us research program wouldn't be possible without the generosity of our participants and the dedication of our researchers to enable these health discoveries. And so thank you, and I welcome any input on my presentation. And thank you so much, Danielle, for running the slides for me today.
Oh, thank you very much, Chandan. Great presentation. And it is great because we are 5 minutes ahead. So I will pass the baton now to my co-moderator, Dr. Roy Beck, and he will introduce the panel and the panel discussion.
Great, thank you, Guillermo. So we have about an hour for discussion. Our 3 speakers from the morning are going to be joined by 3 individuals who I'll introduce momentarily David Klonoff, Rich Bergenstall, and Kelly Watson, and we're going to start with a brief presentation from each of those. I just want to remind the attendees, if you have questions, at the bottom of the screen, there's a Q&A button. So if you click that Q&A button, please put in your question, whether it's directed at one of the speakers or general question for the panel about the topic, and we will try to see how we're going to get to that. So our first panelist who's going to just speak for a few minutes with a little specific background is David Klonoff. He's an endocrinologist and has been really a true leader in the development and use of diabetes technology for many, many years. Medical director of the Dorothy L. and James E. Frank Diabetes Research Institute of the Mills Peninsula Medical Center in San Mateo, California, clinical professor of medicine at UCSF. He's co-chair of the iCode project that we've heard about, and established and is president of the Diabetes Technology Society and editor-in-chief of the Journal of Diabetes Science and Technology. So with that, David, I'll turn it over to you to give you a little talk.
Okay, thank you. I'm going to speak briefly about the future of diabetes data. So let me get that up here. There are gaps and opportunities. These are my disclosures. First topic I'm going to cover in these few minutes is how we analyze CGM data. There are new methods being developed to analyze CGM data. We're going to see these more and more, and we're going to be going from what I call CGM 1.0 to CGM 2.0. And this is an article that I deposited a few weeks ago into arXiv. Several of the authors are on this program today. And what this article points out is that we're currently using essentially simple statistics to describe complex patterns of continuous glucose monitoring, but we're going to be using complex types of statistics in the near future. So this slide is complicated, but I'm just going to say a little bit about it. I'm not going to cover the whole slide, but this shows that we're currently using traditional statistical pattern analysis for metrics like what we see in the AGP or the GRI. Soon we'll be going to functional data pattern analysis. This is known as FDA, but has nothing to do with the regulatory agency. Then we'll be seeing machine learning pattern analysis, and we're starting to get into artificial intelligence pattern analysis. So what we see with these approaches is our current way that most of us look at AGP reports is with summary statistics. We might say the time in range is this much over the entire period, even though there's a lot going on over the, say, 14-day period. Functional data pattern analysis uses statistical models. It looks at the entire time series and can pull out different periods within that rather than look at the entire group. Machine learning, which is starting to be used, uses predictive modeling. It uses algorithms, and it can also work with large language models. Finally, we get into artificial intelligence pattern analysis. This method is the ultimate for looking at CGM data, and it also integrates machine learning, deep learning, advanced algorithms, and multiple data streams. Eventually, we'll see our AID systems based not only on glucose levels, but on a variety of other data streams, some of which we're already hearing about today. And so this is how we're going to go from CGM 1.0 to 2.0. Okay, next.
You have it yourself, I think, to go forward.
Yeah, I'm. Okay. The next topic I want to talk about is what we can do with the CGM data. Currently, we look at the data as we see observable relationships, but we don't necessarily understand why these happen. This is also known as phenomenological relationships. But what we would like to see is mechanistic relationships, so that when we see a pattern, we don't know only what's happening, but why it's happening, because that's how we can direct treatment, if we know why it's happening. So this is an important article that came out a few months ago from a group at Google and Stanford. And I'm working with these people, but I did not have anything to do with this project. And this is called Prediction of Metabolic Subphenotypes of Type 2 via CGM monitoring and machine learning. And what they did was they identified mechanisms of metabolic subphenotypes. They identified the subphenotypes and the mechanisms. And the way this was done was this group used gold standard metabolic testing combined with demographics, and they established these metabolic subphenotypes in a group of subjects, some of whom had no diabetes, some had prediabetes, and a few had diabetes. And they were able to distinguish 4 types of metabolic subphenotypes: muscle insulin resistance, hepatic insulin resistance, beta cell dysfunction, or decreased incretin effect. Then they gave each person a glucose tolerance test and measured the results with CGM. And everybody's glucose tolerance test looked a little bit different. They analyzed these glucose tolerance tests using machine learning, and they're able to link certain patterns on the GTT, which would be almost impossible for a human eye to detect, link them with metabolic subphenotypes of the subjects who either looked normoglycemic or had prediabetes. And what we found was, let me pull this up. I'm having trouble today with this computer. I'll just tell you what we found was that there was a close link between each of these each of these types of metabolic subphenotypes and a certain pattern of glycemia. So the conclusion was that you can use an oral glucose tolerance test to identify a cause of prediabetes. And if you can identify a cause of prediabetes, you can identify a specific treatment for that cause. So we're going now from observable relationships to mechanistic relationships. Thank you.
Thanks very much, David. So our second panelist who's going to give a little talk is Rich Bergenstahl. And Rich is an endocrinologist and executive director of the International Diabetes Center, which is part of Health Partners Institute in Minneapolis. He's a past president of the American Diabetes Association, and he's really worked for many, many years on standardizing CGM and AID metrics, and has been at the forefront of promoting the ambulatory glucose profile, AGP, that we've heard about and learn more about. He's now focusing on how to best implement innovative technology to optimize and personalize diabetes management. Rich.
Thanks, Roy and Guillermo. And I'm going to talk a little bit about going from analysis to action. I know it's all about data today. These are my disclosures. And analysis to action, my disclosures, the next slide. My first comment on the presentations we've heard is that Dr. Clements, Espinosa, Sassari are doing a great job. Thank you. About 7 years ago, I was quite certain that CGM was going to transform diabetes step by step. But I think we've only gotten the first 2 steps done. We've done incredible, go back 1 second, please. We've done incredible work in clinical trials. We have some really well-resourced endocrine clinics that are doing amazing work. But a lot of our work on the next build, please, addressing gaps and challenges and opportunities is how do we implement this effectively in primary care? Because the next build, primary care is where 90% of diabetes is seen. So we better figure this out. The next slide. If you read in today's New England Journal, you'll see there's problems in primary care, death by 1,000 cuts. And the first 3 cuts they talk about is prior authorization, data in the EHR. It's not friendly, it's not quick, and there's no decision support. That's 3 of their 1,000 cuts. Next build, please. But that gives us the opportunity to say, if we can figure out this workflow, and what I'm calling clinical intelligence, I didn't see it in David's list, but I think we can really make some progress. So the next slide. What we're trying to do in our organization, led by Tom Martins and Greg Simonson and others, is the 3 A's: approval, access, and action. A simple smart order set. It sounds simple, but we can now put in a smart order set for CGM, and it takes you to the prescription, the bypasses the prior authorization within our organization, and takes you to the EHR, to the data, at least to the Abbott data, and soon we hope the Dexcom data. And that's important, but that's not sufficient. So what I want to spend my last minute on is we really need action on the data. It's good to have the data, but if you can't act on it effectively, you just have some nice data. So we've developed some tools that we're calling clinical intelligence because we're not quite smart enough to do the artificial intelligence. So here's what we've developed. Next slide. If you just take the time in range and time below range, I know there's amazing sets of data coming. If you take those 2 metrics, you can only be in one of 4 categories. You're doing great, you're out of both, you're too much hypo or too much hyper. It turns out each of those categories has a completely different treatment path. The next slide. And I'm not going to go through it today, but each of those categories takes you down a path where we can tell you this is probably the best path for your patient with type 2 diabetes on insulin. We have it for basal and basal bolus. And so this is what clinicians are really being very happy about. We got the data, but now you're telling me something to do. I'm still making the decision at this point. But you've told me based on this profile, here's a good approach. So finally, in conclusion, I think it's really time that we move from analysis to action, and we start using some clinical intelligence and make room for artificial intelligence to move in from there. Thanks.
That was great. A lot of food for thought for our panel coming up. So our last panelist who's going to talk for a few minutes is Kelly Watson. Kelly is the Vice President of Product and User Experience for Tidepool. Tidepool, those who don't know, is a digital health nonprofit that creates solutions for people with diabetes. Kelly's worked to ensure that patients, clinicians, and care partners are at the center of their product design process, leading Tidepool to achieve rapid market and adoption and grow its global ecosystem, which now includes over 850,000 people with diabetes and clinicians. So Kelly, I'll turn to you.
Thank you so much, Roy. It's a pleasure to be here. I'll give a little bit of background on Tidepool. Tidepool, as Roy mentioned, is a nonprofit organization. We were established in 2013 with a mission to make diabetes data more accessible, meaningful, and actionable. We have 2 core product lines. Our Tidepool Loop automated insulin dosing system was cleared in 2023, and we are privileged to see that now launching in our partnership with the Sequel Twist system, and Tidepool Data Platform, which is our enterprise offering of Tidepool Plus that serves providers, people living with diabetes, and researchers. Our reach and impact to date, as Roy mentioned, our existing tools have supported over 850,000 people living with diabetes and their providers, over 3,000 clinics, and 12,000 registered healthcare providers. Our data visualization platform brings an integrated view of diabetes device data to clinicians and researchers. We centralize that, normalize all of that data, and bring together all of a patient's diabetes device data, including their CGMs, blood glucose meters, insulin pumps, insulin pens, and apps. We've supported over 85 different diabetes devices, some of which you can see here. And our goals, as our previous speakers have mentioned, are to put this data to use And as Dr. Bergenstahl mentioned, and we want to support research and clinical care. We integrate with clinicians' EHRs, providing those workflows where they need it, supporting clinical care, both in clinic workflows and virtual visits, and remote patient monitoring, as you can see here. Our work on Tide Pool Tide, developed with Stanford, supports clinicians identifying prioritized lists of patients who need attention, enabling timely intervention between visits. And so today I want to share and highlight what are the challenges, especially on the product side, as we think about an aggregator like Tidepool. What do we face in the use of patient-generated health data, and where do standards come into play? Echoing Dr. Clements and Dr. Espinosa's presentations earlier, handling multi-source and multimodal patient-generated health data is inherently complex. Effectively handling this data, especially when it's coming in from multiple sources, from CGMs, pumps, wearables in multiple formats and modalities, is complex. These 5 distinct areas are kind of critical stages where we think about these complexities manifesting. The journey starts even before these 5, but where we sit beyond the part of the device creation, as Dr. Clements mentioned, and there is a whole host of issues at the device level as well. But once we look at this data, we're looking at initial account connection, how do we access this, moving through the essential data pre-processing flow, structuring it into discrete data and summary statistics for design choices for visualizations, pushing that data back to the EHR to make it actionable. Each of these areas represent an opportunity where standardization can make a profound difference. And to bring this to life, I'd like to share a few behind-the-scenes snapshots of what it's like to work on the product on a day-to-day basis. As you all may know, even when we have, it's harder to get data where it needs to be. Both supporting patient consent and account linking is challenging. And even when we have standards, protocols like OAuth 2, supporting adoption is needed. Here you can see standard OAuth protocol, account linking deltas between what we see here. This is our engineer writing to our internal teams and looking at novelties on this account linking process for a major device manufacturer. When we look at ingesting data from SMBG data, there's a process to get that into the shape to make it usable for applications like Tidepool's data platform. We normalize that data, but when every data set requires a different cleaning method or key metrics are calculated, inconsistencies, time zones, changing device times, it demonstrates the challenge that we deal with on a day-to-day basis. And we are no longer in a 5-minute sampling frequency for CGM world, for any device for that matter. As sensors expand to support different sampling frequencies and smoothing algorithms and new analytes coming out, we need to adjust our current standards to support what these sensors are capable of. For instance, understanding in research if earlier detection of glucose trends may support timely adjustments in automated dosing systems. And insulin data is inherently even more complex than CGM data, given the ability for events to occur over time and real-time ingestion from these devices and AID systems extraordinarily complex, given the mutability of those events. And as we advance and move towards fully closed-loop system research, additional contextual data streams from wearable devices becomes important. As we heard earlier, how data like activity, stress, sleep, menstrual cycle information can be used to support diabetes care and research in automated insulin dosing systems. This is an area of our work and research. And we're excited to announce a partnership soon, but you can see when we're looking at and analyzing across different data sources, there's different data granularity, inconsistency, lack of standard definitions, a lot of contextual data gaps, and clinical grade validation gaps that we experience, and equity and inclusivity in the validation studies based on skin tone and body size and health status. And importantly, there's interoperability and access gaps here. So how you access data from wearables is not, and diabetes devices. Some offer public APIs, some offer this in a proprietary setting. So syncing this adds complexity. So thankfully, as you heard today, there's a lot of groups working to solve each of these 5 areas: ICODE, AGP standard reports, Argonaut's FireRight initiative, and at Tidepool, we recognize the challenges these researchers face with variable data and believe efforts to support standardization are very important. I won't echo what we see here. I think a lot of this is self-explanatory based on what we saw, but we have these considerations for us to discuss. And as an open source and transparent nonprofit, we're here to support researchers. We have open data sets, as well as our data model and public documentation on our API spec is available in case anyone is curious and wants to advance that as well. All right, I will pause for now. Thank you.
Roy, you're on mute.
Okay, I was following instructions to go on mute when I'm not talking.
Okay.
Thanks. Thanks to all our speakers for 3 really amazing talks. I think set the stage here for an interesting discussion. So we have those 3 speakers plus our 3 additional panelists that you just heard from, and we put together a list of a few questions for panel discussion. I've actually been modifying them myself as I've heard these excellent talks this morning, but just kind of go through some of our thoughts ahead of time, and panelists may want to address some of these: how to facilitate ethical data sharing to promote innovative research and optimize medical care, kind of the pie in the sky approach. So we do want to get to at some point in this discussion. How to ensure that data collected in different settings studies can be integrated and analyzed together. We've heard a number of points on that during these talks this morning. How to improve the usability of data to combine and analyze multiple data sets efficiently, and can this promote cross-disciplinary collaboration, discovery, and generation of new knowledge? Important one is role of repositories and associated resources in facilitating the above. We heard a bit from all of the speakers and then from Kelly about that's really important, I think, for moving the field forward. How much is interoperability and data standards controlled by the device manufacturers? Those of you on the panel have had experience with that. We'll ask you to comment on that, and what have you found successful in getting that done? We'll call on Dr. Bergenstahl particularly as a case study of how the success of taking the CGM AGP and integrating that into the HR, that whole process, and getting the manufacturers on board and getting the HR vendors on board, and just the standardization of the metrics and how all that built, because I think that's kind of a success story that can be beneficial for some of these other devices and data. And finally, how to establish centers and channels of communication for novel CGM data standards, and David Klonoff addressed that in part there too. So I think we can take that slide down. We'll put the panelists on the board here. So listening to the talks, I mean, there's several common themes in just single words. One's standardization, one's integration, one's implementation. I see. And I thought, Rich, maybe we would just start with Juan gave a very nice history of what has transpired with CGM metrics and AGP, but you're the one who's done it, and just it's at the end always seems simpler than it does when you're going down through this dark tunnel to try to make things happen, and have all these varied parties and companies and whatnot, and clinicians and researchers, all different ideas, and maybe going back at least probably 15 years or whatever, just of how that evolved and what lessons were learned.
Yeah, thanks, Roy. It's been a fun journey, and it started long before me with Roger Mazzi and BGM fingerstick data saying there must be a better way to show that, and he came up with this term ambulatory glucose profile, which people today think is like crazy. Who ever thought of that term, and what does it mean? But it seems to have caught on, the AGP. So when CGM came along, we got an expert panel together, and many of you were on that expert panel. and just hashed it out. We had people with diabetes and clinicians and technology experts and actually the FDA sat in as listeners, and just the same sort of thing as an ICODE experience. But to say, how are we going to look at this data and let's standardize the metrics and the visualization of the data? And so that was really how the AGP for CGM came to be. And then after the expert panel met for 2 days, we moved to have the industry there. They weren't at the panel, but then they heard the results of the panel and sat and looked at each other and said, well, what are we going to do? That was interesting, but we each have our own business, and it then took several years to sort of say, well, you all want to do CGM and you're all doing this, and we have an idea and we have a framework. And slowly but steadily, we said, why don't you use this? We're happy to put this out as an example. And everybody innovated on it a bit and used slightly different colors and slightly different, but it started to catch on and make it into the various manufacturers, and then to the ADA standards of care, as Juan pointed out, was a big step to get in the standards of care. And that gave the companies more confidence that this is in the standards of care as one of the recommended ways to visualize the data. And so here we are, and now it has to be continually updated. There's new metrics, time and tight range coming, and other things. So that's been the journey, and now the goal is, well, that standardization, how do you personalize the data and use it to improve practice? So
yeah, I remember Rich saying so many times, it's, well, they did it for electrocardiograms. They got all the companies to agree to have one standard approach to electrocardiogram. We have to be able to do this with glucose data, and you succeeded.
Right.
Yeah, and there's many innovations. There's so many more ways to look at the data, but at least we have a starting point, and hope we build more innovations, into the visualization, be it AGP or another method.
So, Guillermo, if it's all right, there's an overarching question I thought I'd ask each of our panel members to speak on, and which will tie in with a number of the hit a lot of the specific questions we had. That I'm going to start with you, Mark, about what, and then we're going to go through each of the panel members. What do you think a realistic goal is for the next 5 years? And where you think it's realistic we can get to in 5 years, and what's the biggest challenge that you would see in getting there?
Sure. I think that it would be too ambitious to say we'll have one standard that rules them all, because I think there will continue to be some fractionally used standards across the field related to CGM data, insulin data, et cetera. But I think that a realistic goal would be to have some lateral translation tools that allow you to easily move between standards. So at the very least, I'd like to see that as we continue our march toward universal industry-wide standard. I think that one of the biggest challenges we face doesn't have to do with the data standards at all. One of the biggest challenges we face is getting access to the data, right? So Rich talked about the journey to getting data integrated into the EHR from Abbott and Dexcom, and we've taken a little bit of a different approach because we see the EHR as a highly regulated environment, and we see the future of having 22 different security reviews and contracts and integrations directly into the EHR as something that's unpalatable, which is why we created the DDataDoc. So I think this idea of middleware that sits at a healthcare institution between the outside world and the EHR is something that can help solve one of those challenges. But the biggest challenge is really contracting. So if I were going to say there's one single innovation that could make a difference in this field related to data interoperability, it would be universal contracting standards.
That maybe more than we can see happen. David, I'm going to ask you next. I know you're leaving us for another meeting shortly. So what do you see as the realistic goal for 5 years?
Well,
Biggest challenge?
I would mention 4 goals. I think that the iCode will be established as a method for automatically integrating CGM data into EHRs everywhere. Second, I think that iCode 2, which we're currently working on, will become established for integrating insulin dosing data. I think that the DRH hub, which Juan presented, will become established. It'll be very useful for researchers. And then last, I think we're going to be seeing new types of CGM data presentations. AGP has been extremely valuable. It's always going to be extremely valuable. Other tools like the GRI, which is based off of AGP, will have a place. But all these AGP and GRI tools are based on simple statistics. I think we'll go beyond it, and every report will include an artificial intelligence-based analysis in the form of a large language model, and these will be very useful for clinicians. And I think that large language models are going to become widespread faster than some of us think. Thank you for asking me.
Sure. Kelly, how about you? What do you think the next 5 years? What's realistic? Where we can get to?
Well, where I hope we get to, and I just want to share Dr. Bergenstahl's point, and I think we have issues with how individuals access and obtain the right to control and access that information from their diabetes devices and from wearable devices. It's governed in a different way than other electronic health information, like under HITECH and the Cures Act. Like, that access is critical. So what I would like to see, and what I hope to see happen in the next 5 years, is that there is the same right to access and control med device data as there is with other electronic health record data. I think that opens up a world of opportunity, and if we can then look at how consent is scoped, when we consider this data health facts rather than proprietary information, and we consider that as a part of what can be integrated into an EHR, it opens up the door for additional ways that we can scope patient consent. If a patient shares data with a clinician, it doesn't matter if they're viewing that within the EHR or an aggregator platform or a middleware or whatnot. If we can support that scoping of where consent lands, I think, and consider the device data as health facts, that will open up a lot of doors.
Maybe you brought up a really interesting, good point. Where do you think it lies now between with the device companies and their view on who owns the data, whether people own their own data or whether the device companies that collected the data own it? Because that's really a key element of this, right? For what you're talking about, is who owns those data?
Right.
Yeah, absolutely. I think while manufacturers believe that patients own the data, they still are holding the keys to APIs. They're still holding the keys to support EHR integration. And those keys, to make use of that data, we need to unlock that for sure. And policy is what's going to support that change. Looking at med device data similarly as HITECH, and the Cures Act, I think that's what's going to support that change.
Yeah, I think that's important, really important topic. Who else has comments or experience with that of thinking how we get there?
In response to Kelly, one of the things Juan and I have talked about several times is whether advocacy could seek to get all the device manufacturers and their data platforms under the same rules of the ONC that electronic health records are under, in terms of requiring that systems have a mechanism for patients to direct their data.
Yeah.
Absolutely.
That's right.
Right.
So
Right.
if the interoperability and patient access final rule, the Cures Act, all of those today, which were created by ONC-IT, now ASTP, they only apply to EHRs. And so there's this huge gap for other patient data platforms, and that's not just CGMs, just any device manufacturer is essentially outside of the jurisdiction of those rules. I do not work at HHS. I am not a professional political commentator, but if I were to read the tea leaves, the reason that this request for information came out from HHS is because they are thinking about and probably planning to expand those rules. Otherwise, that's how I interpret the existence of this RFI. We actually, Mark and I have a project working with representatives from industry, and Kelly Watson's part of it, where we're sitting down, knowing that this is coming down the pipeline, to set aside, work together collaboratively to develop some policy recommendations about what are meaningful ways in which things like the Cures Act and the patient access rules can be applied to technologies like CGM. So I think everything is incentives and requirements, and I think this is a field where requirements are what's going to drive it.
Absolutely.
Yeah, just
Sorry,
like
Roy. Right. There is an interesting conversation in the chat started by Shankar Subramanian. Shankar, together with Mark Clemens and Juan Carlos, and also David was part of that. Shankar, could you summarize what are the main points of your discussion?
Guillermo, thank you. Can you all hear me?
Yes, you can hear you.
So I thought these talks were really, really exciting. There were a few things that emerged as being very important. Number one is the necessity for having a clinical metadata model that's kind of acceptable across. EHRs don't produce this really. All of us has an opportunity to really do this and make it available or accessible to people. That was one theme that came across commonly. The second was the importance of linking clinical workflows to data analytics workflows. I mean, you have a lot of clinical workflows where you do measurements, including CGM and insulin and other things. How do you link them to decision workflows based on analytics is something. The link between that, for example, Kelly may be the right person to think about this in meaningful ways in terms of trying to integrate this in a decision-making format. The third thing that came across, I apologize, sorry, I apologize. So the third thing that came across was the fact that how do we really, I thought the 4 subtyping that David Klonoff pointed out were very useful, but how do we extrapolate it to therapeutic outcomes and dietary outcomes is the important element to pursue at some meaningful level. So I thought these 3 points were very salient points. And I still, when I'm going to talk this afternoon, I'm going to emphasize on the importance of clinical metadata issues. I really think that this is going to be going towards the future. We have to make this accessible at some meaningful level without losing privacy and issues like that. So I just wanted to mention these, Guillermo. Thank you for giving me the opportunity to mention these.
No, all that's incredibly relevant. I think we're hearing some areas now that actually become not just pie in the sky, but actionable to get us to where we really all feel like we need to get to. Rich, what about the next 5? Where would you like to see things in 5 years, and what do you see as the biggest stumbling block to get there?
Yeah, I think, Roy, I think we must have the data in the electronic record, and I can't say how it's going to happen, and others on the panel may know. I think industry is actually ready to share the data, their APIs, because if it's not in the record, they're not going to use that device. If it's not there, they're going to use the ones that's there. So I think there's whether they share it directly with the EHR, with each institution, which is kind of a pain and contracting, or they put it somewhere that can be incorporated. I think we will have the data in the next 5 years. But I think in the meantime, we really need to work on moving it to action, as I said. And I just think we need a phase of a year or two of some clinical intelligence of making sense of the data that clinicians are happy with, so that the AI is not, a complete black box of saying, well, this is what you should do. They'll get comfortable using that data with a little bit of guidance. They just need some support, and they need a follow-up. Right now, one decision in the clinic is one decision in the clinic, and CGM, you need a decision every 2 to 4 weeks for about 6 months, and then you're there, and that all has to be built into the workflow process. So,
yeah, Mark. I mean, Rich alluded to the contract part there too. What do you think the biggest aspect of the contract part that's problematic? Is it the security? Is it privacy? Is it IP?
No, I think it's IP. I don't think it's security and privacy that are the biggest stumbling blocks. I mean, I think those are fairly routine in healthcare. But I think, for instance, you'll see things like manufacturers who will say, once you receive the data, even if the data go into your EHR, contractually you cannot send the data anywhere else, even though ONC requires that from an electronic health record, you be able to send the data where the patient directs. So the contracts are in conflict with the sort of regulatory obligations. And then the other thing I will say is that I think because the manufacturers have some ownership stake or perceived ownership stake in the data, they also see the data as an asset for which they have to manage risk, which means that any derivative products from their data, like an AI algorithm or even a decision support algorithm, they see as a risk to them and their product. And we've got to figure out as a field how to manage that risk and sort of decouple the risk of the data from the risk of the device. I don't know how we get there, but I clearly see that as a barrier, because that's what holds up the contracting.
Yeah. And just expanding on that point, and something that is, two things can be true. One is that the data needs to be in the EHR. The other thing is that not all of the data needs to be in the EHR. Right. The EHR at the end of the day is a medical legal system of record. Right. It is a bloated accounting system that we use for audits. It happens to be where we put our clinical notes and lookup labs too. It is not the most agile place to do iterative innovation and advanced analytics and visualization. And so I think where I think would be good for us to arrive back to your question, Roy, in the next 5 years is sort of this model where let's take the things that have to be in the EHR and get it in the EHR in the most efficient and regulatory appropriate way, whether that's HL7, FHIR, great. There's lots of thoughts about how to do that. The other is let's get the data into, as what Mark called middleware, right? So whether it's like the Rising Tide Alliance, the Diabetes Data Doc that Mark and I work together, the Tide Pool and the work on the Tide platform, there's a number of these approaches, but where you can really do those advanced analytic approaches, risk stratification, predictive models. You can do that work in an environment that you control as an institution. It's behind your firewall. It has all of the appropriate safety precautions, but it doesn't have the intense onus of a production regulated environment like an EHR, where you can do things like, oh, well, let's change the weights on this model. Let's try tweaking how we define this particular metric. Let's put this data and enrich it with this other component. Maybe it's geocoded data sets. Maybe it's new other wearable device data. So you can really have that agility to think about how you treat patients better with the use of data. So that getting to that point where we sort of see this as two models, right? Like let's do the EHR because it solves billing problems, it solves workflow problems, it solves documentation problems. And let's bring the data into environments that we can meaningfully use to advance the way that we care for patients.
Yeah, I mean, I think you're 100% right about, what's done with the data needs to relate to what the purpose is. And I think, Rich, you would agree that in EHR, it needs to be as simple as possible and actionable, and ideally would have decision support that's built in, but has no more than the clinician needs to see in their brief encounter to see exactly where things are and what to do. And so it's one of these situations where more is worse and less is better, but it has to be presented in the right way. Now I know that's easier said than done, Rich, but I know you and your team are really focused on working on that.
Yeah, you got a couple minutes and you want to have a discussion with the patient, usually these days over the web as opposed to in person, but yeah, so it's got to be simple and both parties understand it, and here's what we're going to do, and you're confident in our decision. Let's go for it, and we'll check back with you in 2 weeks.
Yeah, and it needs to be the same whether, if we take CGM as an example, whether it's an Abbott sensor or a Medtronic sensor or a Dexcom sensor.
Right.
It needs to be sort of sensor agnostic for the clinician as much as possible.
Right.
Yeah, Shandon, what do you see in the next 5 years? What's a realistic goal, and what's the biggest challenge you see?
Yeah, first I'd like to applaud all my colleagues here. These are great suggestions and everything that I've heard. So I agree with these, and I'm thinking about how you would plan the next 5 years. I would take these suggestions, and perhaps it'd be interesting. Let's put this as a suggestion: is maybe we categorize these into an action plan with sort of 3 categories: technical, operational, and strategic. On the technical level, I think Dr. Espinoza, the I code, how do we do the logistics of getting, devices? And Dr. Clemens, you mentioned translating even devices. There might be fractional standards, and how do you translate them in between? So this is dealing with more of the mechanics and technical solutions to bring data into the clinical record. I think that's one area. Then we have our sort of operational ones. I think Dr. Watson, Kelly, what you're saying is absolutely makes sense. I think there's this whole area that's just not really, the All of Us project prides itself on patient engagement, having consent that's understandable, that, patients are empowered to opt in and out of their data. We need to have regulatory compliance, public trust, engagement, this whole area, ethical governance, the ethics. We won't move forward unless we have these things kind of, and the governance of this part. So I put this more in the operational. And then strategic, I think it's about how we build collaboration to make everything move forward, and how we get ONC, how we get the NIH to fund these projects. I think we can take a crawl, walk, run approach. We could leverage projects like All of Us to actually do partnered research studies. Actually, we could, do a pilot study using ENCODE. We've got the Nutrition for Precision Health project. We can actually implement all these aspects through something like that, and through engagement through the NIH and other Fed agencies, sponsor projects that will step us all the way through to make this happen, and working with the ONC to make it standard. So I think maybe it'd be great to take all the suggestions we have and categorize them into sort of a kind of an action plan that will enable us to step our way through.
Well, Juan, I think you already kind of addressed sort of 5 years. Is there more to say?
The only piece, so I agree with everything. I think it's policy. I think it's the separation of EHR data versus other clinical data for insights. The third piece is, we talked about data models, and we're experiencing this with iCode too now. CGMs are fundamentally, at least all the CGMs that are marketed today, are amperometric measurements of glucose, of interstitial glucose, right? The output is a timestamp and a glucose value. And so while there's some feature difference across manufacturers, if you abstract away enough, they're kind of all the same. In the insulin devices, they function different. They're functionally different devices. And it's been really difficult to arrive at a standardized data model across insulin delivery devices. And so what we've relied on is doing what in the informatics world we call canonical models. So a canonical model is the concept that it doesn't get into if a data model is a very detailed specification. This is the shape of the table. This is the number of rows and columns. This is the definition of everything in every row and every column. A canonical model is an abstraction of concepts that each manufacturer would map their proprietary structure to a canonical model. Every EHR, every other consumer of that data maps to the canonical model. And then you essentially work your way through the canonical model to bring all the data together. It adds a layer of complexity, but I think it's the only way to accommodate for all of the variability across devices. So working towards a diabetes technology canonical model, whether that's glucose, insulin, wearables, that would be a huge breakthrough for being able to create a standardized way to approach all of this data.
I mean, we've actually found more challenges with the insulin companies and the CGM companies, and in terms of just them feeling like someone's going to take the insulin data and then figure out what the algorithm is they're using in their AID system, and just being very protective of insulin data, other than aggregating it.
No, that has been my experience as well, and I guess I can understand that, right? Their algorithm is part of their IP, of their value, but I would also just say that the process of bringing a new insulin pump to market is 5 to 10 years and $500 million. They've got a pretty good moat around them. So, learning their algorithm, is, I would say, not that big of a deal, but that's me as a data scientist, right? Like, we can reverse engineer any of these algorithms. The question is why, and what would you do with that information? Like, it's not that helpful if you don't also own the pump. So, maybe don't worry about it so much.
Mm-hmm. Right, great.
I mean, I think one reason all this discussion is incredibly important related to diabetes is, I think diabetes is almost like no other disease in terms of just the number of inputs that go on, where you totally can personalize the approach for the individual by having their glucose data, their insulin data, their exercise data, their meal data, their sleep data, and whatnot, to feed into really individualize an algorithm. Because right now, even though they're adaptive algorithms for insulin delivery, I mean, they're mostly population-based in general. Some of them completely don't adapt.
Right.
Whereas you'd have this amazing amount of data for an individual, and it's being able to aggregate all the data for an individual to come up with things. And I know Mark and Juan, an awful lot of what you guys have been doing is just, I think, with that in mind, right?
Yeah, also if you add to all that, the comorbidities that patients suffer, and also the complications of diabetes. We have not talked about that, but the complications of diabetes are very, very important. And how the data related to complications, how to predict complications, how to act in terms of, as Mark was talking about action, and David Klonoff, what to do with all the data in order to apply that to the management of diabetes, and then the prevention of complications in type 1 and type 2 diabetes. I think that makes it more complex, but fascinating and very important to take into consideration. Also, I have a comment because we have a question. We put together a question about the role of repositories and associated resources regarding facilitating data visibility, and then how they can promote cross-disciplinary collaboration, research, etc. And actually, Juan Carlos, the Diabetes Research Hub, could you clarify that it's going to work as a repository, and at the same time, it's going to work as a hub that will be in link, to many other resources in order not only to, have data there and for researchers, etc., be able to use the data, but also to promote discovery, new knowledge, etc. And what is how do you think that you may work with current repositories at the national level, including our NIDDK repository? And we have here Rebecca, who is the head of our repository in the NIDDK, and she put together, actually, she was the one that has the initial idea about this workshop. And also with international repositories. So are you planning, what is your vision about that? How that may work, and what will be the results, and how this may actually catalyze this in a way that may, make things more agile, and beyond what we were discussing about the rigidities of the AHR.
Yeah, no, I appreciate the question, Guillermo. So for the DRH, the part of the play, as the same as the XKCD comic, right? We don't want a 15th repository. We don't want a 20th thing. It's how do we enhance the ecosystem? So we're offering our plan, what we have today, and also what we hope to grow with, with additional support and funding, includes what we call our resource library. So curated manuscripts, guidelines, R code, applications, software, seminars, webinars. So really a place to put in, trying to curate from across the internet, from across different resources or organizations, as many resources as possible for people who want to understand how to work with CGM data. Today, that doesn't really exist in one place. The second piece is the repository itself, which we are working with the Invenio RDM open source community and a number of the the GRI, the Generalist Repository initiative that's funded by the NIH. We're collaborating with a number of leaders there to understand how our tooling that we've built, I think, can be used by other repositories. So, to your point, Guillermo, there's people have deposited CGM data, not much. Again, sometimes related to the contracting issues that Mark mentioned about making that data publicly available. But there's CGM data today in Zenodo, there's CGM data today in OSF and a couple of other places. But the way that data is stored today by almost every repository that we've looked at is it's a CSV file in some folder-like hierarchy. And so there's no insight into what's contained into that CGM data. So our technical contribution to the field is we've created what we call dynamic storage and display. So a user can still upload those CSV files. Our technology tooling essentially still stores it like a repository with all the appropriate structure. But essentially, we ingest that data into an analytics platform so that if you were searching for a study, let's say that you're interested in glucotypes, right? Getting these subphenotypes of diabetes. And one of the ways to do that is, well, you need a bunch of CGM tracings from a lot of different patients to do those kind of large machine learning analyses. So what our tooling enables you to do is to essentially, through your search field, you can say, show me only tracings that include a time below range greater than 6%. And so it can look through all of those CSV files across all of the different studies and say, oh, okay, there's 10 patients in this study and 15 patients in this study and 30 patients in this study that meet your CGM data criteria. And then you can create what we call a synthetic cohort from those 30 or 40 different patients who meet your criteria, because now you can analyze their data to do those glucotype, those phenotype, subphenotyping analyses from CGM data that meet the criteria that you need. So we've developed that tooling. It's hosted in our repository. We are open source hackers forever. So all of our tooling is open source. Everything's published in GitHub, and we're packaging it now as what's called a microservice. So that essentially, Vivli that Sean mentioned in one of his comments, or Zenodo, essentially can use that same tooling for data that's already stored. So we don't want people to reinvent the wheel. We want to be able to enhance the ecosystem. Right. So NIDDK CR could use would be more than welcome to call on our API and use our microservice to make that type of insight and visibility possible to CGM data.
So Juan, at Jape Center on our public website, we have many CGM data sets from all of our NIH studies, all foundation studies that I actually will get in touch with you to share the data sets with you. I mean, they are, like you say, Excel files that are in folders, but you know, whatever you can do to join them with the data you have, it's quite a bit of CGM data across many studies. It's well annotated.
No, that's fantastic, and we'd love to do that. And you're that's the normal way to store data. It's right, here's this data up, and it goes into this place. And there's good what I'll call sort of library science-ish reasons for that, right? That's how you track individual data objects and digital identifiers. This tooling just gives you this additional level of insight. And you know, we're more than happy to be the ones who host some of this data, but again, how do we support the ecosystem? And I think for us, supporting the ecosystem is let's build software and give it to everyone else so that people can use it. To the extent that we can be that central hub, that curation site that helps bring all of this together and bring those insights together, then that's our goal.
Right. Thank you very much, Juan. And also, Kelly and Mark, how Tidepool and Gluco may actually contribute to make what Juan Carlos is describing a reality. How they could play a role, and also how to work with industry, so industry may be willing actually to provide the data that is needed in order for this to work properly.
Yeah, absolutely.
You want to go first?
And go for it, Mark, please.
Well, I think that we're in a unique position as data aggregators, first to be advocates, and second to help drive, at least by example, the standardization that we're talking about here today. So, there's now a European effort related to data standardization to get data into the electronic health record. It's interesting because, I think our European colleagues are somewhat behind North American colleagues in this push to get data into the electronic health record. But that came up at ATTD, and there was a working group that was formed. So I think by example, by leadership, and by advocacy, I think, Kelly, what would you add to that?
I think the relationships that we have with manufacturers as a nonprofit might be slightly different, but I think at the end of the day, really encouraging device manufacturers to support integration and help them along that technical journey as well is also something that, we have been able to influence. Everyone's still coming up to speed and building their cloud infrastructure to support this type of data sharing. And, that's not where our device companies should be innovating. They should be innovating on the form factor of the device and supporting people living with diabetes and supporting, better algorithms and fully closed loop systems, right? That's where they should be innovating, not on cloud infrastructure to support data sharing or, how account linking is going to work. So helping influence that, being a part of and willing to have those conversations to support interoperability and help bring them along is important.
Sean Sullivan also put a question in the chat about how we convince the device manufacturers that sharing data is of value, and I think I responded in the comment, but I think that we as aggregators and all of the academic innovators as well can also help demonstrate the kinds of care process improvements that can occur through innovation driven by the device data. And if we can then teach the manufacturers how that can help people be more successful on their particular device, I would hope that would be a powerful message.
And Mark, I think you're right. I think you only have to convince one of them.
Yeah.
And the others.
And then it's an arms race, right?
Right.
Yeah, can
I mean, that's the key, is getting one of them, right, Rich?
Yeah, no, can I add to that? Yeah, it's, if you just be sure and have some clinicians as part of this data integration. 'Cause it's nice to have the data in, but if it doesn't, it's got to fit into the workflow too of the clinicians. And if you can get that data to fit into the workflow and it works for one company, that's what everybody's going to prescribe. And it fits my workflow. I got the data, I got some decision support, I got some follow-up, I can bill. It's all there. And so whoever shares that data and it fits into the workflow is what's going to be prescribed. And so I think everybody will have to jump on.
Sure, certainly does influence that and support the stickiness and those prescribing behaviors.
Yeah.
2 minutes remaining.
So we have 2 minutes remaining. We can take one sort of parting word from each. Shandong, let's start with you for your parting words for this group.
I guess the parting words I have is we need to work together to make this happen. And I'm certainly open to any collaborative opportunities we have and how we could leverage the All-of-Us program to further each of these goals.
Yeah, and one thing I've heard that's probably important too, that one of you mentioned, was patient advocacy is probably important too, even though none of that directly represented here. Mark, what's your parting word here?
That there's power in numbers and working together. So when you are one clinician, one researcher, one institution, trying to get these manufacturers, organizations to work together, it's challenging. But if we start to form a working group and it's a cluster of us doing it, it's a more powerful voice.
Rich?
I'd say two concepts: standardization, which this meeting is all about, and then personalization. Sometimes you think those two don't fit together, like it's one or the other, but to make that flow, I think we can do it together if we work on it. So,
Kelly?
Just jumping on that point, I think we need inclusion of additional data beyond diabetes device data. We're going beyond this now. And so while we're getting everybody, all the device manufacturer side, to catch up on cloud infrastructure and data sharing to support pulling this in and standardizing it and standardizing visualizations, now we need to think about how we include this additional information that will power AID systems to come and power additional care models to come, proactive care models to come. So.
Juan, I guess you'll get the last word here.
I think the fundamental philosophy that needs to drive all of this is that we are just stewards of this data. This data belongs to the people who generate it. And if our responsibility as stewards of that data is to make sure that it gets used to deliver the best possible care for each individual, and that drives the research and innovation that makes better care possible for future generations. And as long as that is the philosophy that drives all of this, I think we'll get there, working with industry, working with healthcare organizations, working with payers, working with government. But we all have to be on board that is the philosophy that drives all of this work.
Okay, Guillermo, back to you for final words.
Great. Thank you very much. It was a fascinating discussion. Thank you to all of you. And Rebecca, this is back to you. I think that you can talk about what is coming for the second session.
Yeah, good afternoon. Thank you so much. This was an excellent discussion. We're going to break for lunch. This is going to be a 30-minute break. To the panelists and speakers, there are questions in the Q&A. Please take a look and answer them as you are able. And we will see you back at 1 p.m. Okay, good afternoon. Welcome back, everyone. It's 1 o'clock. We're going to get started. We will proceed with the second session of the day with this more in-depth look at the integration and interoperability efforts for data standards specific to NIDDK disease research areas. This session is chaired by Dr. Shujin Wang and Dr. Alex Banks. Dr. Wang is a program director at NIDDK with the Diabetes, Endocrinology, and Metabolic Disease Division. She manages projects that develop tools for data science, leverage high throughput data, and create computational or combine computational and laboratory methods to model biological processes relevant to DEM research. And Dr. Banks is an associate professor of medicine at Harvard Medical School, leading obesity and diabetes research. He also oversees energy balance core facility at Beth Israel Deaconess Medical Center in Boston. Dr. Banks chairs the International Indirect Calorimetry Consensus Committee to establish scientific standards globally. Dr. Banks and Dr. Wang, I pass it on to you.
Fantastic. Thank you much. Thank you very much. This is a very exciting session. I'm looking forward to it. Shujing and I will be chairing, and we will be with you until about 4 o'clock. So this session, session 2, will focus on identifying and addressing the gaps, challenges, and opportunities related to data and metadata integration, as well as interoperability related to diabetes, obesity, nutrition, liver, digestive, and kidney diseases. The structure of this session will consist of presentations by research mission areas, followed by an integrated, cross-cutting panel discussion encompassing all of NIDDK research areas. We'll begin with presentations in the digestive diseases and nutritional research areas. Our invited speakers are Dr. Wendy Court and Dr. Shankar Subramanian. Dr. Court is a distinguished professor of medicine in the Division of Geriatric Medicine and the Nancy Anschutz Chair in Women's Health Research at the University of Colorado Anschutz Medical Campus. She's the director of the Energy Balance Assessment Core for the NIDDK-supported Colorado Nutrition and Obesity Research Center, the NORC, and associate director for the Lumen Family Center for Women's Health Research. She serves as chair of the steering committee for the NIH Common Fund Molecular Transducers of Physical Activity Consortium and director of the Colorado Specialized Center of Research Excellence on Sex Differences. Dr. Court's research is focused on novel factors that influence musculoskeletal adaptations to exercise and on the metabolic actions of estrogens. She has received continuous funding from the NIH as a principal investigator since 1991, has more than 300 publications, and is currently the PI for the NIH U54 and U01 awards. Dr. Court, her presentation is on measurement of body composition by dual X-ray absorptiometry in single and multi-site trials, lessons from the MotorPack. Dr. Court, why don't you go ahead and share your screen? Perfect, and put it in presenter mode.
Oh boy.
There you go, down at the bottom.
Yeah, it's not on the screen. I'm expecting it. Do
There
you see
go.
the right?
Yes,
right
we got
thing?
it. We got it.
Okay,
You're
great.
perfect. Please take it away. We're looking forward
Thank you
to it.
very much. Thank you very much, Alex. So I wanted to share today some of the challenges that we've uncovered as a result of doing body composition analysis across multiple sites in MotorPack. I plan to cover 3 areas. First of all, a general overview of how body composition is measured by DEXA, because I think that's important for understanding some of the challenges. And then I'll just touch on some of the issues that people should be aware of in running either single site or multi-site studies. So the measurement of body composition by DEXA started back in the late 1980s. DEXA replaced dual photon absorptiometry, and you can see that it brought a number of advantages to how we could measure both bone, which is the primary utilization of DEXA, and body composition. I was a postdoc back in the late 1980s when DEXAs came on the market, and through one of my mentors, Stan Burge, had the good fortune of having the opportunity to work with the software engineers at Hologic to develop their body composition analysis software. I worked with them a number of years. They had some very poor assumptions that they started with. I think the most glaring being that water was a negligible component of body composition, where in fact we are 50 to 60% water. And when we worked through some of those initial problems, in about 1992, they told me they couldn't improve the software any further. So I went ahead and published this paper comparing body composition by DEXA with hydrodensitometry or underwater weighing, and basically showed that DEXA was missing fat in the trunk region, which is very important given the metabolic dysfunction we know is associated with abdominal obesity. A few years later, they had made some improvements. There were still some problems then. I think by the time I published this paper in 1998, I was at least convinced that DEXA was now the reference method for measuring body composition in humans. Initially, I think the approach that DEXA used was pretty straightforward. It was just a single X-ray beam that passed through the body many times, and because that beam was perpendicular to the body that it was going through, the projected area of the body or the object was the same size as the area of the object. So the scan back then went in this rectilinear fashion up and down the body, many more passes than I have represented here. It wasn't many years before both GE or Lunar and Hologic advanced to doing fan beam measurements. And here you can see that the analysis might get a little bit more complex because the area, the projected area of the object is now larger than the actual area being scanned. So more assumptions that go into the conversion of area, reference methods that mimic bone, lean, or fat tissue, and how you actually get to measurements of mass. I think it's become standard that with fan beam technology, there are about 7 passes across the body. To get to body composition, Hologic and Lunar, or GE, essentially do two compartment models of body composition. The initial 2-compartment model is bone versus soft tissue. And this is a pretty easy measurement to do or distinction to make, because the attenuation of X-ray by bone is about 4 orders of magnitude greater than the attenuation by soft tissue. So this means that for any pixel or voxel that contains bone mineral, it is going to be identified as bone. So this large difference in attenuation enables the clear distinction of bone pixels and edge detection so that the area of bone can be easily identified. But this also means that the composition of some soft tissue that is either overlying or underlying bone can't be measured directly because the bone signal obscures the soft tissue signal. In this next slide, I'm going to focus in on that narrow region now that captures fat and lean tissue. So we're talking about attenuation coefficients that are down around 0. And there are materials that can be scanned that have different attenuation coefficients that can be used to mimic fat and lean mass. And at least early on, Hologic used stearic acid and 0.6% sodium chloride as their reference standards to define 0% lean and 100% lean. So in this model, something that has an attenuation coefficient of around 0.01, that pixel would be viewed as about 50% lean, 50% fat. The 2 major manufacturers, as I mentioned, are Hologic and GE, which took over Lunar. And these are the current models of instruments that are being used. For Lunar, I think there's just one, the iDEXA. The Horizon is the current model for Hologic. It has 3 different versions of the Horizon, the A, W, and C models. I don't know anyone who has a C, so I'm not going to be talking about that today. But the Horizon A and W instruments have some interesting differences. First of all, the Horizon A has many more detectors, which might seem to be a good thing. But when they look at how the total body scan for the measurement of body composition is performed, in contrast to the usual 7 passes with the array beam being perpendicular to the body, the A instrument only makes 3 passes. So time for scanning is much reduced. But these 3 passes now are in different orientations. There's one that's perpendicular to the body, and then there are 2 scans or 2 passes that are done at about 30 degrees to the body. And I've got this asterisk here because we've run into some problems with these two instruments, not necessarily generating comparable data. And when I talked with Hologic about this, I learned that they have not done any formal comparisons of body composition measured on the A and W instruments and are not aware of any publications that have done this yet. And I actually spoke with Tom Kelly, who was the guy I worked with back in the 1980s and 90s. He's now the senior principal scientist at Hologic. So if I just show you what I think is going on here, this is what I showed you earlier about the fan beam. Because this makes 7 passes, there are actually 7 of these arrays, and you get a pretty good coverage of the body when you do this kind of a scan. If you look at the Horizon A, though, since it's doing only 3 passes and the scans are at this different orientation, it doesn't seem to me that it would necessarily be logical that you would generate the same data. So I was a little disturbed that Hologic didn't have a little bit more transparency about how these two instruments compare in their measurements of body composition. So if we talk about some of the challenges for doing single site studies, presumably, if you don't have to change instruments, you're using the same DEXA instruments for all measurements. So the challenges are things that you might predict, making sure your operators know how to operate it correctly. But something you also have to pay attention to is whether data remain reproducible after there's been a software update or a maintenance visit. In terms of software updates, Hologic now publishes what they call their statements of equivalency. I think that was because many of us complained that data seemed to be changing as a result of software updates many years ago. I would like to see a little bit more transparency than this, though, just saying that data are identical. I would like to see the data that were generated that led to that conclusion. In terms of maintenance updates, I'm sharing with you some data that were collected from one of the MotorPack clinical sites. This was at Duke. And what you're looking at here is the difference between scale weight and total mass measured by DEXA. And we know the measurement of total mass by DEXA is not accurate. It usually varies by 1 to 2 kilograms. But you can see that through many years of MotorPack, the difference, it's going to vary a little bit among individuals, but it remained fairly consistent until this point in time. And when our coordinating center showed me these data, I asked them to ask Duke if they had a software update or a maintenance visit. And indeed, they did have a maintenance visit that generated this change. So we haven't resolved this yet, but because the accuracy of measuring total mass by DEXA is not great, all measured masses should be adjusted or corrected to scale weight. And you can do that using the percent fat and lean generated by DEXA. And MotorPack plans to publish a methods paper to document this recommended approach. When we go to multi-site trials, because DEXA outcomes vary, the best option is to use the same instrument across sites. Even when you do that, there are factors that will generate some variability. And I just want to point out this last one, the analysis mode being set to classic or NHANES. I don't have time to go into the background about this, but this was based on a single published paper, and it was the norm. It was the default for a long time. Hologic now uses the classic as the default, but this has a huge impact on the levels of adiposity and lean mass that will be measured. If it's not possible to standardize the make and model of DEXA instruments, certainly you have to have some sort of cross-calibration process to implement. And in the past, there was a whole body phantom that could be sent around to all the clinical sites to do this. We did this in MotorPack to just a couple of sites This is 2 GE instruments and then 2 Hologic instruments looking at the fat mass, lean mass, and total mass. I was shocked when I saw these data that they are so different because this is the same object being measured on different machines. But then I learned that, and I don't think many people know this, that the whole body phantom that Hologic developed cannot be used on the Horizon instruments. For these next, I'm going to run through a series of slides just showing you all of the MotorPack clinical sites, again showing you the data I showed a few slides ago, the difference between scale weight and total mass. This is Advent Health showing that DEXA underestimated mass, but pretty consistently across time. Same for Ball State, same for Cedars-Sinai, Pennington Biomedical Research Institute, San Antonio in their first instrument and their second instrument, Alabama Birmingham, Texas Medical Branch in Galveston, our clinical site in Colorado, the Duke data that I've already shown you, and then our last clinical site is East Carolina, which is very different from all the rest. And this is the only Hologic Horizon A instrument, which highlights my concerns. They also had a problem for a while that required maintenance. So we had 6 individuals measured the same day on a Horizon W and a Horizon A instrument. You can see that the measurement of total mass differs by more than 3 kilograms. These differences are also transferred into measurements of fat and lean mass. And when I asked Hologic about this, they suggested that we've adjusted everything to scale weight, the body composition would remain the same. But in fact, body composition is not the same on these instruments. It wouldn't matter if we adjusted these to scale weight because we're looking at relative adiposity and lean mass here. So I think we have a problem with the Horizon A instrument not generating similar data as the other Horizon or probably the GE instrument. So the last 3 thoughts to leave you with is that DEXA has been considered the reference method of assessing body composition for more than 25 years. I think we've come to rely on it, but I think there are now reasons where we have to start questioning the use of this in multi-site trials. The inability to use a whole body phantom to cross-calibrate body composition across sites is a real concern. I don't know how we're going to cross-calibrate now. MotorPack will be publishing this methods paper on the approach we're using to harmonizing data, so hopefully we'll provide some insights on this. Thank you.
That was fantastic, Wendy. Thank you so much. So we'll be taking questions at the end of this session after Shankar's talk. So Shankar, why don't you go ahead and share your slides. Dr. Subramanian, our next speaker, is a distinguished professor of bioengineering, computer science and engineering, cellular and molecular medicine, computer science and engineering, and nanoengineering. He was the chair of the bioengineering department at the University of California at San Diego. He holds the inaugural Joan and Irwin Jacobs Endowed Chair in Bioengineering and Systems Biology. He was the founding director of the Bioinformatics graduate program at the University of California at San Diego. Before moving to UC San Diego, Dr. Subramanian was a professor of biophysics, biochemistry, molecular and integrated physiology, chemical engineering, and electrical and computer engineering at the University of Illinois at Urbana-Champaign. He chaired the task force which led to the creation of the new School of Computing, Information, and Data Sciences at UC San Diego. Dr. Subramanian, his presentation is Making Omics Data Fair, the Need for Data and Metadata Standards. Please take it away.
Yeah, thank you so much, Alex, for your kind introduction. And I thank the organizers for inviting me for this really very important and exciting topic. I would like to really talk about, in fact, opportunities for data and metadata standards and the need for them. And can you see my screen, please?
Yes, we see you.
Can you all see my screen?
We see it.
Okay, fantastic. Fantastic. Okay, without any further details, I'll dive into My thing is not moving. I don't know why. I apologize. My screen is not moving.
Click on this slide.
Oh, now it's moving. Okay. So what is FAIR? I mean, FAIR is findable, accessible, interoperable, and reusable. And most of you have seen majority of the data standards or requirements today are FAIR. And in fact, when you go to the FAIR website, which is defined by GoFair, which is an organization that conforms to FAIR standards or gives rules for FAIR, you can look at all the, I'm not going to go into all the details. This is really FAIR, guidelines. And you can see the presence of this word metadata in so many times. In this in findable, accessible, interoperable, and reusable. In fact, I built a wordgram from this metadata, and you can from this set of guidelines, and you can see the occurrence of metadata so dominantly across this entire set of guidelines. So this really shows or points to the importance of really data sharing and why we need metadata. And I'll go more into details in this. I want to walk through examples and use cases of making data findable, accessible, interoperable, and then reusable. I'll give you some use cases. For example, imagine you want to find all DNA sequence variants data from Latino male Down syndrome subjects from Kids First and identify metabolomics data from the National Metabolomics Data Repository and provide links for downloading such data. Imagine a user wants to do this, a biomedical researcher wants to do it. What would it take to do this? In fact, if you're really a sophisticated computer person, then you can go into each of these sites and try to download this data. However, the common, biomedical researcher is not very sophisticated in terms of accessing these. So we really built or developed in the Common Fund data ecosystem a structured vocabulary and ontology, which really contains all these well-defined metadata terms, which includes core entities, container entities, and then subjects, biosamples, and file assays. And a user can end up choosing, for example, a subject, a human, for example, biosample, blood, for example, and file. And then he or she can look at a project or a collection of projects. And then they can look at the specific source where the data is coming from, like Kids First or Metabolomics Workbench, and then use this to build a table of all these data. For example, Kids First has the data in leukemia and heart defects and Down syndrome. And then you can use all these filters to obtain specific criteria. And all of this is possible only because of the metadata description and the ontologies that underlie this. I highlight this in the next slide even more in detail. If you look at ontologies, for example, there's gateway to data search and discovery using a graphical system where you can look at all these graphical, structured vocabularies and structured ontologies. And then you can look at the menu options to pick and identify the data that a user is interested in. He or she will pick, online using a very simple graphical interface, objects which they want to filter into. And once they filter, they will end up getting outputs like this. For example, sequence variants from Latino male Down syndrome subjects from Kids First and Metabolomics Workbench. They will get a graph search query, and then the query will result in a network, which gives you the graph, gives you a tabular view where you can download the data sets from these different resources. This is one of the requirements where metadata impels an end user to discover knowledge, new data, or data types that are currently present and use it subsequently. The second thing I want to point out is to make data interoperable across distinct data repositories. This is one of the huge problems in modern, data science. If you want to find, for example, all data on PNPLA3, the gene discovered by Helen Hobbs to be involved in fatty liver disease and non-alcoholic steatohepatitis across gene, metabolome, drug, and glycome data resources, how do you integrate and harmonize all these data towards integrative analysis? Such a task is going to be, help us really decide what types of future tools we need to build. Here's an example. For example, I take all these different resources and we need to build general, Apiters or Jupyter notebooks. And these Jupyter notebooks or apps or APIs will help us really create smart application programming interfaces, which will help us dive into each of these without a user really knowing all the details of the structure of each of these data resources. And he or she can end up saying, for example, in GTEx portal, which contains gene tissue expression data, These are all the data sets associated with PNPLA3. It occurs in all these tissues, for example. For instance, in LINCS, which is another common fund resource, PNPLA3 is obtained in all these distinct perturbations and CRISPR signatures. Or in Metabolomics Workbench, you can look at pathways, reactions, metabolites, and studies associated with PNPLA3. Or you can look at in Glygen, all the glycomics data or the glyco data that is connected to PNPLA3. Or you can look at Pharos, which is a drug data resource on all the diseases that are known to be associated with PNPLA3. This is an integrative approach towards learning, and this again requires a metadata structure, an API, an interface, and going beyond that. I want to now tell you about transforming data into knowledge. We need APIs, workflows, and tools. Without APIs, workflows, and tools, you cannot take all this vast data and convert it into meaningful knowledge. For example, imagine you have genomics data, transcriptomics data, proteomics data, epigenomics data, metabolomics data, and you want to do an integrated analysis of all this data towards reconstructing networks, towards looking at causality or correlation across different types of data, towards identifying biomarkers. To accomplish all this, we need to be able to, number one, harmonize same types of data, harmonize different types of data, integrate all this data, and this cannot be done in the absence of a strong metadata framework and APIs and application programmed interfaces. For example, these data repositories can be very distinct, and they can have different formats, different structure, different data types. How do we integrate all of this? We need to build workflows and pipelines that will help people integrate this. This morning, we had a number of talks which talked about glucose monitor data, continuous glucose monitoring data. How do you integrate it with electronic health record phenotypic data? This requires workflows, which we discussed this morning across various speakers. An example of this is, for example, I'm going to give you a use case. We always learn in biomedicine through use cases. Imagine you want to find in humans all genes regulated by transcription factor KLF4 from ChIP-seq data and identify in GTEx resource data that are enriched for KLF4 target genes. Then we need to be able to parse the query that we are making. It's a very simple language query, and we need to parse it into human, database encode and GTEx, experiment type ChIP-seq, molecule type gene, transcription factor, target gene, molecule, specific molecule KLF4, relationship regulator enriched by. This should be encoded in the query by the machine using APIs. The detailed query, then I will not go through all of this. The detailed query then translates this into a workflow. The workflow is essentially a set of programs, methods which are modularized so that the modules can be integrated for annotating the peaks, for applying thresholds, for rank ordering peaks, for visualizing. And these can be in turn contextualized to organisms, to human, and to GTEx specific data. And then you can look at all the targets and then do the computations required for enrichment and then visualize it using the targets. This is the kind of workflow that is needed to make things happen. We need to contextualize such workflows across different modalities of data towards linking, towards identifying new knowledge, towards building new knowledge from these resources. Another example of this is, for example, what mechanisms drive liver cancer? This is a real example of a researcher who came to us and said that, imagine, I want to discover what are the types of data that I can use to discover liver cancer mechanisms. This is the liver, standard example of a liver. These are the spatial, or single cell transcriptomics data that is parsed using UMAP. And then these are all the connected integrative analysis from the metadata on the disease associations, such as NASH, non-alcoholic steatohepatitis, hepatitis B, etc. And then this liver has, for example, from measurements in metabolomics, 186 species with the common, within liver and plasma and common species. And these are the enriched species in this common 48 species across. And cholesterol is highlighted as a species. In fact, the transcriptional measurements produce sterol biosynthesis and sterol cholesterol biosynthesis as key mechanisms. And these can be reconstructed to build a network or a hypothesis in terms of saying These are the mechanisms that give rise to liver regeneration in steatohepatitis or dysfunctional liver regeneration in steatohepatitis. So to build such a map, such a query, we need metadata, we need standards, we need ontologies, we need workflows, and we need to be able to integrate such data. Can we automate this? Key question. Next example, how do different, this is MotorPack study was mentioned in the previous study and in the morning. How do different mammalian tissues respond to exercise? MotorPack had this humongous study in, for example, starting with rats and now in humans. They did endurance testing on male and female rats and profiled 19 tissues and then measured the epigenome, the transcriptome, the proteome, the metabolome across all this. How do you integrate all this data without any metadata knowledge? And this is pointed out both in the previous talk and in the morning talks that it's really essential for us to have a knowledge of the metadata associated with these for us to harmonize and integratively analyze this data. I'll now talk about the next need for clinical metadata for cohort discovery. This morning, we had a number of talks which dealt with cohorts associated with continuous glucose monitoring. In fact, the Stanford speaker spoke about the 4 subtypes associated with diabetes, which really can be inferred from the clinical using combination of clinical metadata and data. And there's a need for minimal clinical metadata that's harmonized. And I spoke to all of us folks this morning about the absolute need for us to build this so that the community can really use this. This is a huge gap and a challenge. In fact, we need FHIR. This morning, there's a mention of FHIR, which is fast healthcare interoperability research, which is emerged. That's a really interesting gold standard for modeling clinical data. In fact, I'll show you an example of how FHIR can be used. It encodes SNOMED CT, RxNorm, LOIN, Coberon, etc. And then it includes different data types can be integrated, value sets, and cardinality. In fact, dbGaP is now trying to adopt FHIR as a model for looking at clinical metadata. I'll give you one example. For example, diabetic retinopathy. Imagine you want to infer from this clinical finding, you want to discover retinopathy with type 2 diabetes mellitus. You need all these types of metadata. You need to have disease annotations. You need to have body region annotations. You need to look at the visual system disorders. You need to look at which eye region is being affected. You need to find retina finding. You need to look at the disorder posterior segment of the eye or other things. And then you can integrate it with all kinds of other omics data towards understanding retinopathy with type 2 diabetes mellitus. This is only possible if you can harmonize and structure data with metadata.
1 minute remaining.
Thank you. Need for interoperability. There is really, I'm going to go through this very quickly, very strong need for interoperability across different resources. We need to have continuously integrated, harmonized, and shared data. Another example is, for example, between Kids First and Metabolomics Workbench, you can see that same terms have different terminology. We need to harmonize these terms using a FHIR model. Now, the last point I want to leave you with, and some people say, oh, ChatGPT can do this all. Can we leave it to large language learning models? Why not? So the answer is the following. I'll show you a use case, an example that we did from my lab. We really compared the very best ChatGPT models available, SC Mamba, SC GPT, GeneFormer, for transcriptomic data, trained on 60 to 120 million cell RNA sequence data and fine-tuned for pancreas and myeloid. Look at how poor the performance is in terms of accuracy, precision, recall, compared to SURAT, which is a statistical model, and compared to ground truth. Even SURAT doesn't produce ground truth, but compared to SURAT, all of these things, all of these learning models are very poor in recall and accuracy. Still, we need context. Without context, LLMs cannot capture context currently available data. I can go into all the issues with tokenization and things like that, but I mean, the point really that I want to make here is there are really, serious issues still even using LLM. We need to start bringing in context. What are the last points, actionable items? We need to ensure that all data generated in NIDDK projects provide metadata following ontologies, control vocabularies, and standards. This, I think, will NIH-wide or NIDDK should really think about this. Develop and implement minimal clinical metadata model that can aid cohort selection. All of us is already starting to think about this. Enable all data tokenized along with metadata to bring context into AI LLM approaches for analytics. Without context, you can have hallucination and there's no real outcome from LLMs. build use cases for the community to learn how data can be used to develop hypotheses. We really believe strongly in very good use cases which can help the community. We want to develop modular workflows and APIs that enable interactive and dynamic building of interactive data analytic strategies. And lastly, construct user-friendly interfaces that are biologically meaningful and intuitive. These are actionable items and recommendations based on the theme that the workshop has been organized. I'll stop at this point, and in the panel discussion time, we can go into details in each of these actionable item topics. Thank you for your attention.
Thank you for a fantastic talk. That was so much in such a short period of time. And we have 5 minutes for questions for Shankar and for Wendy. I'm just going to start with the very first question because looking at all of those different data types that you presented, Shankar, and all the different metadata types, how would you even propose to standardize all the metadata types across all the multi-omics, metabolomics, RNA-seq, genomics, variants? Where do you start with that? That's an enormous problem.
This is truly a confounding problem. We have made a modest start in the common fund data ecosystem in terms of building a common metadata model across very simple omics strategies. In fact, transcriptomics, metabolomics, and epigenomics. We've established an initial model that integrates about a dozen plus, common fund projects which span these omics. In addition, we just started recently establishing a minimal clinical metadata model. During the panel discussion, I can discuss more about this. And this minimal model will enable cohort selection, which is a really serious problem. Imagine I want to find out all diabetic patients who are only males in the age group of, for example, 30 to 50, and who have body mass index of over 25, and who have an A1C value of over 6. If I want to do that, there's no easy way to do it today, unless we define the clinical metadata standards. And we have to respect privacy, but at the same time, we can build metadata models, and we are working, in fact, with both dbGaP and all of us, and with the Nutrition for Precision Health and Common Fund projects towards building such a minimal clinical metadata model that can do this. The game is only beginning. I mean, you're right that it is not, we are not claiming that it is done, is far away before we can get to this point.
Got it. Thank you. Wendy, I have a question for you. So you were talking about how these machines, how these DEXA machines have different standards, and even the same standard doesn't work the same in the different machines. How do you get the data to be comparable between the machines and even the data formats so they're comparable across all your different sites? And does MotorPack have enough clout to come back to the manufacturers and try to enable them to standardize their data formats and how you can make the data interoperable?
Yeah, great questions, Alex. We've spent a lot of time trying to harmonize the data across the MotorPack clinical sites. Harmonizing the output formats and informats from GE and Hologic is time consuming, but it's not that difficult. We can do that. The real challenge is trying to cross-calibrate or standardize
1
to
minute
some
remaining.
platform. And we are having to rely on some published data and other data that were collected at some MotorPack sites that directly compared 2 instruments, or in some cases 3 instruments in the same individuals. But because we no longer have a whole body phantom that we can use for multi-study sites, we need more of those direct comparison studies. Nobody wants to do those. Those are very routine things, but we need to get those data published because I think that's going to be the only way we can do it. And do we have enough clout? I have been unsuccessful in trying to get Hologic more engaged in providing solutions, but we're working on it.
Great.
Alex actually raised her hand.
Oh, I'm sorry.
Maybe we can.
Go ahead, please.
Thank you, Wendy. I have a question for you since we all work on the MotorPack. Yeah, I wonder, in the early beginning of microarray, there were so many different brands and, people are using different things, but they still try to compare the result by at least have before and after of an intervention from a single platform and just look at the delta kind of thing. I wonder whether that approach can be applied to multi-pack DEXA data.
I do think that looking at changes across platforms will be more consistent, but Ashley, as you're very well aware, we're publishing a lot of data across sites based on just an acute exposure. So we have only one DEXA measurements. So we have to have a way to standardize for those sorts of comparisons. And they're very important because both muscularity and adiposity are important determinants of a lot of metabolic outcomes and molecular signaling factors.
Absolutely. Thank you both very much. So that concludes the first part, which was about the digestive diseases and nutrition research areas. And we're moving on to kidney, urologic, and hematologic disease research areas. So next up, presentations. Our invited guest speakers are Doctors Jim Hokanson and Claire Yang, who will be presenting on the measurement of lower urinary tract function. Let's see, so Claire, are you going first? Could you go ahead, or is Jim going first? I think Jim is.
I'm going first. Oh, Claire's going first.
Claire, go ahead. Okay. Claire, why don't you go ahead and share your screen?
Yes.
Got it. Okay, so Dr. Yang is professor of urology at the University of Washington and is chief of urology at Harborview Medical Center and staff physician at the VA Puget Sound Healthcare System. Her areas of clinical practice and research interest include neurology and lower urinary tract function. She's been a longstanding investigator in NIDDK research networks, most recently in the Multidisciplinary Approach to Pelvic Pain, MAP, and the Symptoms of Lower Urinary Tract Dysfunction Research Network, LEARN, in which she served as the co-chair of the steering committee. Dr. Yang, please take it away.
Thank you. Just a quick question. Are you seeing a screen that's appropriate?
Yes,
Okay.
I see your slides. Looks perfect. Please proceed.
Okay. All righty. Well, good morning, and thank you to the organizers of this meeting for inviting me and Jim Hokanson to participate. We're going to talk about data that is slightly different from the other types of data being discussed today. This is not about omics or genes and molecular data. This is physiologic measurements of lower urinary tract function, and specifically the function of the bladder and urethra. So we're talking about organ function. One of the main reasons to measure lower urinary tract function is to develop or select treatments to reverse or improve dysfunction, which is a core philosophy of all of medicine. But is lower urinary tract function worth measuring? And to give you the scope of urinary tract disorders, most humans who live past middle age or into middle age and past middle age will have experienced temporary or long-standing lower urinary tract dysfunction with or without symptoms. And for many who experience urinary symptoms, it can be very distressing. For example, involuntary loss of urine or incontinence represents loss of a deep-seated human function. And in many of these people, it represents a loss of their human function or humanity. And for that reason, the extent and impact of these problems make lower urinary tract dysfunction an NIDDK mission area. So lower urinary tract function and its measurement is many things. It's multidimensional. There's no single biological marker that can encompass the function or assess the function, reflect the function of the lower urinary tract. It is dynamic. There are different functions of the urinary tract at different times. It is complex. It requires the coordination of two nervous systems, the autonomic and somatic nervous systems, with two end organs, the bladder and the urethra. The function is anatomy specific, based on sex, based on age, based on surgical reconstruction. and it is modulated by factors outside of the urinary tract, such as emotions, diet, medication use, mobility. All these factors and more impact urinary tract function, and it makes it really challenging to measure and standardize these functions. So since we're talking about organ function and not things that are probably on the mind of many of the people in this meeting, I would like to review the function of the lower urinary tract so it'll give some foundation to understanding what we're going to be talking about later in the talk. So the function collectively is known as the micturition cycle. The first function of the bladder is to store urine until it is socially appropriate to evacuate. The bladder is a reservoir, and the storage or filling phase is where we spend 99.5% of the micturition cycle, where the bladder fills with urine. You can liken it to a diastole phase of the cycle. The bladder also stores urine at low pressures, which is known as compliance. The second function of the lower urinary tract is to evacuate urine efficiently. This is the systole phase, where the bladder squeezes long enough and hard enough to empty the bladder contents, and the control muscles or the sphincters are open. There is a low pressure contraction for evacuation in the healthy state. In this cartoon, the bladder, the urethra, the spinal cord, peripheral nerves, and brain are diagrammed to show the different anatomic structures that are involved with the micturition cycle. Now, it would be a lot easier to measure urinary tract function if the system we were dealing with were not so complex. In birds, there is no reservoir for urine or for feces. All of the waste products from the kidney, and I don't know if you can see it here toward the left side of the picture of the animal, the urinary contents and the gut contents all converge into a chute known as the cloaca without any reservoir or sphincter muscles for containment. So there's not very much to measure as far as lower urinary tract function in this organism, but that's not the case for humans. So what happens physiologically during the micturition cycle is shown here in this cartoon. The top row shows the bladder and the sphincters in the different phases. The second row shows muscle activity from electromyography tracings, demonstrating the engagement of the sphincter muscles. The third row shows bladder pressure over time and measured on the y-axis as centimeters of water, and the x-axis is time. And on the bottom row is measurement of urinary flow as it's being evacuated from the bladder, measured in cc's per second. And again, on the x-axis is time. So starting at the top left, the filling phase, the bladder fills with urine. That's where we spend the majority of the time. When the bladder is perceived to be full and it is socially appropriate to evacuate, what happens is that the sphincters open first, and you can see by the EMG that when they open, the muscle activity stops. Then there's a rapid rise in detrusor pressure, which then plateaus, and with the rise of detrusor pressure or bladder pressure, there is urine evacuation, and the urine flow continues and then tails off as the bladder empties. And then when the bladder is empty, the sphincter muscles engage again, the muscles close, and the cycle starts all over again. So this is how we measure urinary tract function. Collectively, the measurements of urinary tract functions are called urodynamics, short for urinary tract dynamics. if you look on the picture on the right, you'll see a sagittal view of the human pelvis in a woman, and there is a manometry is performed through a catheter in the bladder, and the catheter measures pressure, and that's shown to the right side of the cartoon. But there's also an inflow of fluid that is pumped into the bladder to reproduce the micturition cycle of filling up the bladder. Now, it's a super physiologic filling, but this is the best we can do. And real-time filling is still very problematic. Real-time filling and measurement of pressures, that is. We also measure pressures intra-abdominally with a catheter in the rectum, and in women, it can be placed in the vagina. There are EMG electrodes placed on the pelvic floor muscles, on the skin of the pelvic floor muscles, and all that can be documented on a tracing which shows all the measurements that are being taken. In many urodynamics laboratories, we also perform X-rays, real-time X-rays, to look at the bladder shape and look at the passage of urine as it occurs during voiding. And so along with these manometric tracings, we are also collecting anatomic images. So what are we measuring? During the urodynamics, we measure both the functions of the bladder, bladder storage and voiding. During storage, we measure pressures. We calculate compliance. We identify occasions of detrusor overactivity when the bladder is squeezing, perhaps when it's not supposed to during the filling phase. We measure points of at which urine starts to leak from the bladder. And we also measure sensations, and we document all that on the real-time tracing. We can also measure urethral function with electromyography, as well as pressures within the urethra. And during the voiding phase, we also measure pressures. We measure urine flow as it leaves the bladder and collects in a device to calculate the rate of urine flow. We can also measure how much urine is left behind in the bladder after voiding to calculate voiding efficiency. And then we have fluoroscopy or X-ray imaging during the study itself. So now I'll turn the talk over to Jim Hokanson, who will discuss the gaps, challenges, and opportunities in collecting and sharing urodynamics data, and I'll stop my share right now.
All right, Jim, you have your slides coming up? Yeah. Great. All right. So just as a way of introduction, Jim Hokanson is an assistant professor in the Joint Department of Biomedical Engineering at Marquette University and the Medical College of Wisconsin. Dr. Hokanson is currently a co-investigator for NIDDK's LEARN network, where he, in collaboration with Dr. Yang, is examining how urodynamics or physiological studies of the lower urinary tract relate to lower urinary tract dysfunction. He directs the Pelvic Diagnostics and Therapeutics Laboratory, which focuses on improving electrical stimulation therapies, improving physiological diagnostics, and the application of machine learning in the field of benign urology. I can see your slides. Please go ahead.
Awesome. Thank you. So I've broken the second part of our talk up into two parts. One focused on standards related to data collection. The other one focused on data sharing, and with these focusing on gaps, challenges, and opportunities. A bit of a disclaimer here, particularly in terms of urology research. In general, surgical departments tend to receive a lot less funding relative to internal medicine in terms of funding, and this seems to be decreasing over time. Specifically in urology, there's a move towards eliminating research years in urology residencies. There's fewer than 10 that remain nationally. In general, and I've heard this multiple times from urologists and urogynecologists, surgeons are paid to do surgery, not research, and this is a challenge in the field. Urodynamics, I sort of define it as physiological testing of the lower urinary tract. And I think a lot of the exciting work that's being done in this field, frankly, is being done by Europeans, presumably due to differences in healthcare between the US and the European system. The impact of this is that there are fewer and busier clinical collaborators, and in general, it's harder to do clinical/translational urology research. So I just want people to have this in the back of their mind while they're thinking of the talk. That being said, a positive spin on this is I think there are tons of opportunities here. My 10 plus years of being in this field, I've seen talking to people with how impactful urinary dysfunction can be, and I think there's a lot of opportunities. The other thing to be aware of is that urodynamics in general is a sensitive subject. So here's a lady getting urodynamic testing. Everything seems nice and straightforward. But keep in mind, she had these catheters placed, so her legs are spread. Someone's going in and poking in her pelvis, putting in catheters. And so in general, there's this need to balance our diagnostics with physical invasiveness and the emotional burden that it places on the patient. So in terms of the standards, our standards body is the International Continence Society that defines a lot of standards related to urodynamics. I'm listing some paper references here. In general, though, my experience has been these standards are not strictly followed. Part of that is a training issue. I think another big part is that in a lot of cases, these standards, it's really unclear how they impact outcomes. And so there's a little bit more wiggle room where people aren't following the standards perhaps as closely as they should be. Just to give some examples of standards, some that I think are good and one that I think is questionable. The first really nice standard is that one of our standards is when we're calibrating pressure, we're supposed to zero it to atmosphere and then place the pressure catheter into the bladder, at which point the pressure will increase. Oftentimes, though, if you look at these traces, the pressure in the bladder starts at 0, indicating it's been zeroed in the bladder, which means that we really don't know what the absolute pressure in the bladder is. Everything is now a relative assessment. And this is something I struggle with explaining to people. And in general, I think this standard is a really good one that should be enforced, and we don't do a great job. In contrast, here's another standard that talks about an abdominal pressure. Now, in terms of abdominal pressure, the idea is you want to be able to tell the difference if the bladder muscle contracts versus if you cough or you press in the abdomen, where the latter would cause an increase in bladder pressure, but it wouldn't be from the bladder muscle contracting, it's just because you're increasing pressure on the abdomen. So we often place a catheter either in the vagina or in the rectum. And the standards say, always place in the rectum, only place in the vagina if it's impossible to place in the rectum. My experience has been that women prefer to have this vaginal placement, physicians prefer to place it in the vagina. And so here it's not really clear that the standard is helpful. And so you can have someone goes a lot of efforts, I follow the standards, I do my best, and then someone go, no, you haven't followed the standards, you use this vaginal catheter, shame on you. Okay. So I could go into a lot about standards, but I only have limited time, so I really want to focus on what I saw were some big challenges and opportunities. A lot of these standards focus on standard urodynamics tests. Those standard urodynamics tests are uroflowmetry, so peeing into a container, cystometry, filling the bladder and looking at pressure, and pressure flow studies where, again, peeing into a container, but also monitoring the pressure while you do it. And I think the big question that needs to be asked are these the best tests that we should be measuring? And my general feeling is they're not encompassing enough. We need to be measuring other things. So in particular, I'll explain this in the context of incontinence. Stress incontinence I explain as a little bit of urine loss that comes with like coughing or sneezing or laughing. We tend to think that this is due to pelvic floor support loss. And then we have urgency incontinence, which I explain as an inability to make it to the bathroom in time where you essentially pee all over yourself. And we tend to think of this as being from bladder dysfunction or something we call diffuse overactivity, which is these inappropriate contractions of the bladder during bladder filling rather than at the end. So I'm going to bring up my little anatomical diagram here, and you have this pelvic floor, you have the bladder, and then of course there's this tube that connects the bladder to the outside world called the urethra. And in general, my contention is that we don't put enough emphasis on studying urethral dysfunction. In fact, one of the most common types of incontinence isn't really stress or urge, it's actually the combination of them, which we call mixed. And a group of us have been trying to push that we really need to be studying urethral failure for mixed incontinence, as well as for stress and urge. Now, this is just one area that I think we're neglecting. I also think we need to be focusing more on brain dysfunction, vascular dysfunction, assessing reflexes and what's going on there, as well as genetics. So then the question is, well, how do you sort of assess the value of your diagnostics and the standards, whether you're doing a good or a bad job? And what we do is, I think what most people do, you have some diagnostics, and based on that, you make a decision, I'm going to go with treatment 1 instead of treatment 2. Now, this sounds great, but the problem is what's the evidence that you're basing this decision off of? So a lot of people say, yeah, my diagnostics are great. I was going to do treatment 2, but I decided to do treatment 1. My question for them is, well, is that actually a good decision? What is the evidence that you're basing that on? And for a variety of reasons, I think historically we just haven't had good evidence in place. And in fact, now there's this large area of debate in terms of what is the role of urodynamics and how are they contributing to things. In general, my feeling is that largely we're falling back to treating symptoms in many cases. And so something that I'm proposing as an alternative approach is essentially a prediction modeling approach, where for whatever reason you're going to go ahead with a treatment. Based on that, you gather baseline diagnostics, you gather outcomes, and you try and create a prediction model that relates the two. So that's the idea that I think we need to do more of, but there are some needs that we need to get over in order to do this well. One is we need more data. I'll be talking a lot more about that in the second bit. This needs to be shared data. We need better tests, and we need multiple tests. So a lot of times people say, oh, you're the Mr. Urethra person, you really like the urethra. But my contention is for some multifactorial dysfunction, we need to be measuring a lot of things and seeing how they all come together to cause the dysfunction that we're seeing. We need well-measured outcomes. It's not uncommon. Someone gets treated, they get sent home. Maybe they come back and complain. Maybe they're so upset that they never come back anyways. But we need to be measuring those things. And so then just to bring in a little bit in terms of the role of standards, this is really tricky because I think in our field, there's a lot of expert opinion standards, things that I think could go multiple ways. We really don't understand the impact. And if I wanted to do a prospective study, what I would advocate for is we use our best knowledge in terms of what's known. And then we have quality control mechanisms in place to make sure that everyone's doing the same thing. Okay, so on to part 2, data sharing standards. And I really had to scratch my head here in terms of what data sharing standards existed. And I knew I'd read somewhere that something existed, but for the most part, it's not happening. I don't know if anyone's seen the Treasurer Sierra Madre, but this quote came to mind: badges, we ain't got no badges. And I applied this to urology with data sharing standards. We ain't got no data sharing standards. That's technically not true. I'll show you some things in a bit, but I think there's a lot of work to be done. So it turns out this paper that I couldn't quite place, one of the reasons I couldn't find it was in a standardization of terminology of lower urinary tract function as an appendix on how to digitally exchange data across different data types, how to format it into a common data type. And I think this is like a great evidence in terms of like how serious we are about this. It's like, oh yeah, just throw in some random appendix somewhere. So we don't do great. In fact, our data sharing standard is essentially sharing images. So you get your PDF, you print it out, you share it with somebody else. Hopefully you can make out what's going on. If you want to zoom in, and maybe it's a little tough to do that. Here's just another example PDF showing this. Now we do get reports. Dr. Yang mentioned that we can annotate when events happened in addition to measuring all of our signals. Hopefully these things are lined up appropriately, because at particular times in these events you can get numerical values associated with that time, but oftentimes our events are like in this general area something is happening. So this can be a bit of a challenge. So again, we have a lot of work to go here in terms of data sharing. Some more modern efforts in terms of data sharing that I wanted to point out. This one's from 2018 from Children's Hospital of Philadelphia, or CHOP, looking at structured data entry systems for EHR. I'm going to zoom in. The urodynamics portion is on this upper right here. I'm going to zoom in on that, and they have a technical part and a subjective part. And I think the subjective part is really important to note, because a lot of urodynamics is someone staring at this piece of paper and going, I think I see this, I don't think this. And then the question is, well, if you gave that to someone else, would they come up with the same conclusion? And my feeling is oftentimes that's maybe not the case. In general, it's unclear that this has gained any traction. That being said, I think moving towards structured data entry systems into EHR would be useful, and it's something that, in my experience, I don't think the field is at, and we could probably use help with. In terms of whether or not this is gaining traction, I wanted to highlight that this is still an abstraction of the raw data. If you want to go back and be consistent in your subjective assessment, have a bunch of people analyze this or see consistency across sites, that would be really tough to do because you've abstracted away the raw data. You don't have the raw data to share. Here's a more recent example coming out of Europe from Bristol. They have this really big, fancy 360-row Excel file. Looking at this sort of overwhelms me in terms of filling it out and the time that's required. And then they have drop-down menus that you can fill in for each thing. Again, it's really unclear if this is going to be taken up by others. That's something that I think we struggle with. So in the remaining time that I have, I wanted to bring up 3 issues around data sharing. Again, lots of questions here, not a lot of answers. But I think in terms of fixing problems, the first thing is to sort of identify the problem, and then hopefully we can move forward with getting those solutions. One is we lack centralized repositories for raw data. We just don't have them. Again, a lot of times it's sharing PDFs back and forth with people. And I'll talk about why I think that's going to be a bigger issue in the near future. It's unclear what data needs to accompany urodynamics data. And this isn't necessarily metadata as much as additional clinical data to give context, although some people may define that as metadata. And then how do we collect this data efficiently? And I'll motivate why that's important in a bit. So in terms of the need for centralized data repositories, to put some context in how our data are captured, right now you go into the urodynamics clinic and it's maybe 30-minute session, about 10 minutes of that's actual collection, a lot of it's just setup. And one of the concerns with that is the artificial nature of this, that it's in this room, people are poking and prodding you. And so there's been some work out of the Cleveland Clinic that's working on a device that can essentially unfold, get pushed through the urethra into the bladder, and then folds up again so it stays in the bladder. And the idea is that this will be sent home with somebody, and now instead of 10 minutes, you're looking at something like 10 days of data collection. And I think we just really have no idea how to start working with this data and processing it. And this notion that we're gonna print out this big like 500-page PDF and go in and start working with it, it's just, I don't think it makes sense. So I think there's gonna be a need for advanced signal processing methods and techniques. And that's where I think having a centralized data repository that you can start to work with will be really important. The other thing, and I alluded to this earlier, is that urodynamics, a lot of it is subjective interpretation. So I'm going to give an example of this with the true story overactivity. Again, this is this contraction during bladder filling that's thought to contribute to incontinence. The problem is it's open to interpretation. So you have someone looking, oh, I think this is it. Oh, maybe it's not. I don't know. Someone else goes, this definitely is. And the problem is, of course, when the interpretation like that is variable and you're trying to relate that to some outcome, it becomes really challenging because everyone's seeing something different. So here's from 4 examples. The first 4 examples from one site where it was marked as yes for the true story overactivity. The true story overactivity is this increase in pressure, this hump. This is this DO, and then this I indicates that there is incontinence associated, there's leaking associated. This next patient, longer duration, smaller amplitude DO, followed by really large DO leading to incontinence. Do these things matter? Are they the same? Are they different? Is there different pathophysiology? We don't know. Now notice the Y scale here. If we zoom in on patients 3 and 4, you notice that the Y scale is really small. So these are really small, and you notice we're getting these little oscillations going on. And again, currently our current practice is, yes, these people all have DO, and then we try and make some assumptions about what's happening. And the hope is that we can get a little bit more fine-grained with this, and that's again where I think we need these shared data repositories to figure out the signal processing algorithms, and then additionally to try and relate that to other things. So that's, one bright aspect of this. We currently have essentially one manufacturer of urodynamics equipment in the United States. So there's one single data format. And so I think that's a plus, although of course there are downsides to it. That being said, we have not really established how to electronically archive these data across sites. That's just not something that's done. People are really comfortable hitting the print button and getting the PDF and saving it somewhere, not so much with sharing the raw data.
1 minute remaining.
Okay. In terms of beyond, we need to do more in terms of a minimal data set and establishing that. Lots of questions here. I think at the end of the day, we need initiatives or committees to come together and say, this is what we're going to do, and we're going to try and do it at many sites. We've tried to do it as an example for stress urinary incontinence. One of the problems is when talking to clinicians, they essentially say, this is a lot of work. We don't have time for this. And so the third thing is essentially, we've talked about a few big data dollar initiatives here. I think we need to get beyond that, get to efficient consenting, easy data entry, easy onboarding of sites. How to do that, though, I think is very much a question. One thing to note, people have pointed me towards PCORNet. In practice, we've used a lot of REDCap, and we're starting to use MyCap for direct data entry for people. In terms of benign urology, I think there's an interest in all of us, but most people in the benign urology field really don't know what's going on there and how it can help us. So I'll just bring up our summary opportunities and challenges. In particular, when it comes to minimal data sets, one thing I wanted to add is I think this is probably best to be done in conjunction with a particular study where we say we're going to do our best effort here rather than having someone from on high saying, well, this is how it's going to be. And then everyone else saying, well, thank you very much. I'm just going to keep doing my own thing. So anyways, I wanted to thank Learn, which has contributed a lot to my thinking on this, as well as SUFU and their research network. Thank you.
Thank you so much, Jim and Claire. Once again, we have the 15th data standard XKCD presentation, which I think has been a recurring theme just because we keep seeing that over and over again. The issue that, I mean, the one good thing that comes from your talk is that there's one manufacturer and so one data format. So at least you don't have the data format issues, but still trying to get standards is really challenging. There's a question from Shankar in the chat. Shankar, do you want to unmute and read it yourself?
Yeah, it's actually comment/question. I mean, I liked Jim's comment with reference to very valuable to have structured EHR data. I don't know if you know, Epic is making serious efforts to build posterior tools in order to provide some level of commonality. No, they are nowhere near having the point where it is incredibly useful, but it is the starting point for looking at data. And we should encourage the clinical and health care community to embrace this much more. And you folks, you and Claire are really in tune for doing this with reference to this specific area. The second point I want to make is the raw data. I really believe that in the future, raw data is very important because it can be reanalyzed in different ways and also fed into, large language models and things like that. But to do this, we need cloud. I don't know how whether your large project has embraced the cloud as a modem for doing this. The cloud is the right place to have it, but make sure that it is containerized as well as it contains Jupyter notebooks and things like that that can be used for analysis of data or normalization of data. So I'm curious to know if you have thought about cloud resources to accommodate your raw data.
Yeah, thank you for both comments. I think a cloud approach makes sense. I think the challenge is, at least with our backgrounds, sort of knowing with PHI how to do this well, how to train people, what the HIPAA concerns are, and how to do this also effectively. Who's paying for it is a big question. I very much agree, though, that I've had experience with a lot of data formats that not relevant necessarily to urodynamics, and having sort of that exemplar use case where you're really making sure that it's not just there, but it's also usable, whether that be through just good documentation, the Dockerization you mentioned, Jupyter Notebooks, things like that. But I don't know. I think we're very much open to suggestions in terms of good use cases. We've had to work on de-identifying. A lot of this has PHI in it. I've written code that will go back and post-process these binary files to essentially de-identify them. But I'd love to have feedback from people as to how to do that.
Great. There's also a question from Daniel Gossett. Daniel, do you want to unmute? I can't hear you, Daniel.
How about now?
There you are. Yeah,
All right. Thanks, Jim and Claire. Outstanding presentation. I was just curious if, in your experience in Learn and other studies, if there are any elements of the clinical context that have emerged as perhaps priorities to develop initial metadata that should be captured across studies.
Claire, do you want to start off with that, or I have very strong feelings on this? But
well, there are the components of the variables of bladder pressure, but and maybe urethral pressure. Those are what we would call key components. Urinary flow rate, but at what point during the micturition cycle are we going to collect these data? Which are the most important? What are the subjective responses associated with those points should we collect? So in my mind, that's a tough question to answer from a clinical standpoint, just knowing how many different opinions my colleagues have about the importance of these individual data points. So I'll let Jim give his strong opinions.
I think at the end of the day, these are conversations that we need to be having, and that we're really not. We're starting to do this in the SUFU Research Network to start having them. One of the things I skipped through relatively quickly was an example of stress urinary incontinence, where a group had gone to a ton of effort to really define what additional things need to be known. But from my perspective, it's like an all-star group that has a ton of resources, and they're saying this is the perfect thing. And then at the end of the day, I think they're somewhat surprised when no one else is able to match what they're doing. I'm envisioning to some extent there being potentially layered contribution things of like, here's a very, very, very minimal data set of like the minimum things. Here's like the next level, bronze, platinum kind of thing in order to contribute. I don't know, we have success. I saw Dr. Scales on in terms of the CDC and the umpire work there. The challenge there is that it's, at least from my outsider perspective, it's a really well-funded group, right? And so if you have tons and tons of money that you're throwing into these things, I think getting nice big data sets, because everyone sort of wants their own additional measurement that it's being thrown in, then it's really nice. But if you're trying to do this sort of in a standard day-to-day operation, that's where it becomes really challenging. And you have to really fight with people in terms of what is really the minimal data set rather that's actually doable.
Great. Thank you both so much. And Jim, thanks for the badges. We don't need any badges for data standards. I absolutely love that. So that concludes our section on kidney, urologic, and hematological disease research areas. And that brings us into diabetes, endocrinology, and metabolic disease research areas. And Shujeng is going to chair this part.
Yeah, thank you, Alex. So yeah, as Alex said, the next mini session, the third and the last, will focus on diabetes, endocrinology, and the metabolic diseases research areas. Again, we will have two outstanding speakers. First, we will hear from Alex Banks, who just did a wonderful job as a moderator of the first two mini sessions. Since Alex already been introduced, I will not repeat again, but let Alex start his talk. Yeah, Alex.
Okay, fantastic. Thank you so much. So we're going to talk about international standards and data sharing in obesity and energy balance research. And I start with this slide of Lavoisier's laboratory from 1792-ish, where they were first starting to measure metabolic rates. And just to say, in contrast to continuous glucose monitoring or metabolomics or RNA-seq, this is an old field that has struggled with standards for centuries. And I think we're just starting to get a hang of where we're going with this. So there we are. So for anyone who doesn't think about indirect calorimetry every day like I do, so we have these little cages that we put the mice into, and we measure their oxygen consumption, carbon dioxide production, and through this we can estimate their metabolic rate using another very old equation. 75 years ago, the Weir equation came up with a way to take the oxygen consumption rates and carbon dioxide rates and be able to estimate the rates of energy expenditure. And so with these modern systems, you can measure the food intake, metabolic rates, physical activity, body weight, and this is especially relevant to NIDDK research areas, feeding behaviors, dietary patterns, thermogenesis, things that regulate metabolism, torpor, exercise, physical activity, obesity, nutrition, microbiome, all of that stuff. So we think about that a lot. And this is going back to something in Mark's slide from this morning, where if you think about the data, the world's metabolic physiology data, you have this transition from raw sensor values up to processed data, where you can then go from measurements of a various sensor that's happening every second over days and days, and then you take that over multiple cages and multiple animals and multiple groups, and you can ultimately process that into some meaningful information through data visualizations, group analysis, statistical analysis, and ultimately you can get trends like this one showing that energy expenditure is highly dependent on temperature, ambient temperature in mice, whereas mice kept in warm temperatures have a much lower metabolic rate than mice kept in colder temperatures. So all of that is coming out of all of these sensor measurements, and they all need to be analyzed. The problem, being such an old field, is that the standards were not set 200 years ago. They weren't set 50 years ago. And really, they were only just starting to be set out about a decade ago. And so I'm showing you an example here of one particular signaling pathway, which the pathway isn't that important, but you've got some ligands, some receptors, and some transcription factors. And people have knocked out various components or overexpressed or inhibited with monoclonal antibodies various components and measured the metabolic rate phenotype of these molecules in mice. And the great advantage of mice is you can take genetically identical animals and just change one factor. The problem here is that in these 16 different studies, we have 8 different ways in which the data have been reported. So it's much like badges, we don't need no badges, except we don't have any standards. So people have been reporting basically at random whatever the system has been spitting out. And so these measurements that are in purple or blue, we now consider them to be incorrect by dividing by body weight. That's sort of the wrong way to report data. And values where you've not divided by body weight, we now consider those to be correct. And so it comes to this question of, well, who's responsible for fixing this? Who's responsible for establishing the standards? If you look back, it certainly wasn't Lavoisier's job. But now, if you look around the room and you say, whose job is it to get us out of this mess? You get Spider-Man pointing at each other. The academics point to the journal editors, and the journal editors point at the funding bodies and then back at the academics. So I've had this conversation with journal editors and said, well, why do you keep publishing values that are divided by body weight, which we all know is wrong? And they say, it's not up to us to establish the standards. It's back to you. And so they point back at me. And the same with the NIH and other funding bodies like the Wellcome Trust. It's really on the academics. So basically, it's my fault. So I accept that. And moving forward, we've tried to actually establish these standards. So what I've been working on for a little while is the Consensus Guide to Preclinical Indirect Calorimetry Experiments with the International Indirect Calorimetry Consensus Committee, which is a lot. But that to say, I have assembled 79 experts, including our next speaker, Julio Ayala, who has been writing about standards for preclinical biology for quite some time, and he's been a true leader in this area. And we have members in the US, we have members all over the world, but I'd like to point out these NIDDK-funded sites, the Mouse Metabolic Research Centers, the Diabetes Research Centers, the Nutrition Obesity Research Centers. All of these NIDDK-funded sites have signed on to agree to these standards and to take them going forward, as well as many international partners. So why is this a problem? I mean, standards are great, but does it actually matter? So here's one very simple example. This is a confusing example from the myostatin knockout mice. So the myostatin is a circulating factor that blocks the growth of skeletal muscle. And when mice or cows or dogs and even some patients are lacking myostatin, they have muscles that grow almost uncontrollably. They're big and muscly. And so you read an abstract which comes from this analysis, and it literally doesn't make any sense. We show here that myostatin null mice have a significant reduction in fat accumulation with increasing age compared to wild-type littermates. So these mice are skinnier, even at the setting of normal food intake, normal body temperature, and a decreased metabolic rate. So somehow they're skinny, but they're burning less energy, and that makes no sense at all. It really just boggles the mind. And so this study here showed control and myostatin knockout mice, and these myostatin knockout mice, when you divide by body weight, do in fact have a lower metabolic rate because they're dividing by such a larger body weight, 36 grams compared to 28. Now, if you reanalyze this data, and this was in the supplement of their paper, and if you look at myostatin knockout mice where you've done it correctly, these muscle-bound mice have a higher metabolic rate, and that makes more sense. So they have a higher metabolic rate and a higher food intake, and that's actually why this matters to do the analysis correctly. So how are we going to fix this? We're going to establish the global standards for preclinical and clinical indirect calorimetry measurements by establishing data formats, analysis methods, and there was this landmark paper published in Nature Methods in 2012, which is widely considered as sort of the mark in the sand by which we're going forward and establishing our analysis methods and some graphical representations. So as a large committee, it doesn't even matter so much exactly what the standard is, just if we can all agree to one common standard. So for these metabolic rate measurements of oxygen consumption and carbon dioxide, we're just saying milliliters per hour, not milliliters per minute, although that would be fine. And all of these where you're dividing by body weight, those are not appropriate. And the energy expenditure, kilocalories per hour, not divided by body weight. We're not using watts and joules per second or kilojoules per hour, although these would be fine. This is not the standard we've agreed to. And so we've established some standards moving forward, hoping to move the field forward from where we are now. And I'm going to present one very simple, trivial example of how these standards are helpful and what happens when you don't use them. This is the question of why do mice on a high-fat diet become obese? And you take a group of 32 genetically identical littermate mice, and you start them off, and after 2 weeks, you randomize them onto a high-fat diet or low-fat diet. And you can see that even though genetically they're the same mice, the high-fat diet mice gain much more weight. They have very similar amounts of lean mass, more fat mass. And this is how we like to represent the data, because if you divide this, if you show a percent body composition, while these mice on a high-fat diet do have a higher percent body fat, this representation shows them with a lower percent lean mass, which is misleading because they actually have the same amount of lean mass. So we like this one and only show this plot if this one is also shown to have the full picture. And then we kind of get into what indirect calorimetry can show us. So these are data measured every 5 minutes, and it's showing the metabolic rate of mice on a high-fat diet, which are consistently higher than those mice that are on a low-fat diet. And you can see in the dark, it's much higher, in the light photo period, it's higher, and overall, it's higher. So these mice on a high-fat diet have a higher metabolic rate than the mice on a low-fat diet. And what about food intake or energy intake in kcals? It's messy, but you can see that the mice on a high-fat diet seem to be eating more. And when you look at the cumulative food intake, mice on a high-fat diet are eating more calories. When you put that all together, energy balance is the food intake minus the energy expenditure, and every 5 minutes, you sum up the energy in and the energy out, and you can see the cumulative amount is that these high-fat diet mice are in more positive energy balance and therefore will be gaining weight. And so the answer is these mice have higher food intake and higher energy expenditure, but slightly greater food intake, and that is why they're in positive energy balance. That's sort of what we're doing as a consensus committee, saying this is how you represent your data. And what happens if you do it incorrectly? So the oxygen consumption is very similar to the plot of energy expenditure, where the high-fat diet mice at all times seem to have a higher energy expenditure. And when you do a regression plot like this, body mass versus oxygen consumption, the high-fat diet mice have a higher energy expenditure than the low-fat diet mice. But if you were to divide by the body weight, which is what was in most of those studies in that initial table, you can see that now these high-fat diet mice seem to have a lower metabolic rate than the high-fat diet mice have a lower metabolic rate than the low-fat. And you get this really strange-looking plot when you do this analysis, which suggests the very largest mice in the entire study have the lowest metabolic rate, and it just doesn't make any sense. And that's why this is so important to get these standards out there. So we've developed this program called CalR. CalR is supported by the NIDDK, and it's for all investigators to use for their indirect calorimetry data. It has a graphical user interface. You don't have to know any coding, and people can upload their data from any of the manufacturers, and they can instantly get these plots within a few seconds and get the analysis of what their data means, and it's following these standards. So just a word about CalR. CalR, this is a snapshot that I took just a few days ago. 30 days of users showed people all over the United States are using it in most of the major research areas, not comprehensive, but just a snapshot. And CalR has now been used about 85,000 times, which is amazing to me. And what it does, it establishes the standards for data, metadata, and analysis. And by being so fast and easy to use, it's become the global standard. And we've kind of de facto become the standard data method of storing, analyzing, and visualizing the data. And it's also been able to promote collaboration and sharing of data because we now have a data standard file. I did not include this But to be honest, there are 3 manufacturers, and we've created a 4th standard. So we have created a 4th new standard for indirect calorimetry, just like all those cartoons. We established the metadata for data sharing. This is the committee, and everyone has ideas about what it is, but it's going to include all of the usual suspects, like what are the species, genetic background, what is the age, sex, and diet, the body weights, the litter size, the diet, the bedding, what calculation method. All of these are really important metadata components to be able to compare studies between institutions and between settings. But we still have work to do. So if you just look, this was last month or the month before in Cell Metabolism, there were 2 different studies that are either doing their analysis correctly, as you see down here from this one study, where they're doing these regression plots, and all of their analysis was really admirable. And then another study where they're dividing by body weight, even in 2025 in a flagship journal. So we still have work to do in order to get the standards out there and to promote this. So our standards paper is in revision. It's not published yet, but it's not a surprise to anyone on that committee that journals are not enforcing these standards, because it really hasn't been clearly stated yet. So just to summarize where we are, we have some accomplishments. We have some community-driven, large multinational agreements of what the standard should be, and we have a paper in revision. We realize that even once we have these standards, those are not fixed in stone. Those standards will evolve over time as we have new understanding of what the data means and how it should be represented. This is a ton of work to get everyone to agree on what these standards are and how to get past them. And it's really only the first step. Once we have the paper out there, we need journals on board, we need funding agencies on board, we need everyone, even who's not on the committee, to agree that this is the way that the data should be represented. The data that comes out from these standards will be standardized. It will be AI ready or LLM ready. We'll have data and metadata ready for large-scale analysis. And I feel like that is a huge step forward. Once we have that and all the data standardized, getting a data repository should be a relatively straightforward next step. So here's the overview of the data ecosystem for indirect calorimetry. So users load in their data into CalR. They put in this minimal data metadata to say which animals are in which groups, what are the essential features, what are their body weights, what are the time ranges, what are the photo periods. They then visualize, explore, and do quality control so you can see what the data look like. You can see the group means or the individual means. You can do these regression plots. And then when you find data that looks strange, and the equipment breaks all the time, you see air leaks that can give you a metabolic rate that looks like it's 3 times higher than it should be. And you can remove outlier values or simply remove broken cages. We've worked on this user interface for about 10 years to really get it nailed down. You then move to statistical analysis once you've passed quality control. And this last part, which is in gray here, is to take all of this data and to contribute it to a data repository. And this is something that I hope is going to happen in the next year. We have a promising proposal moving forward to be able to have everyone in the world share their data and get some large-scale analysis going.
1 minute remaining.
Thank you. With that, I'd like to thank the members who have been working on CalR, William Bernard, who's been leading this project, among others. And with that, I will stop. Thank you very much.
Thank you, Alex, for the wonderful talk. It's really exciting. Next, we have Dr. Julia Ayala. Dr. Ayala is an associate professor at Vanderbilt University and the director of the NIDDK-funded Vanderbilt Mouse Metabolic Phenotyping Center, where he led the work to refine standards for performing metabolic phenotyping tests. His research focuses on delineating molecular mechanisms mediating the weight loss effect of GLP-1 receptor agonists while actions on the central nervous system. Without further ado, Julio, it's yours.
Thank you, everybody, and thank you to the organizers for the invitation. Can you all see my slide?
Yes.
Perfect, great. Well, thank you very much. And very similar to what Alex just spoke about, the Mouse Metabolic Phenotyping Center Consortium, or MMPC, has really had one of its key missions has been to try to standardize the methods that are used for assessing various metabolic phenotypes in rodents, in mouse models. And so today I'm going to talk about our efforts and some examples on considerations and recommendations for reporting studies on glucose metabolism in mouse models. And I'm particularly going to focus on some screening, for lack of a better term, screening tests, and then some more involved tests that are the typical ones that are used for assessing glucose metabolism in mice, but this by no means covers all of the types of tests that are used. So typically what we start with is a mouse model with a suspected aberrant glucose phenotype. And then the screening tests that I'm going to focus on are the glucose tolerance test and the insulin tolerance test. And then depending on the types of outcomes that come out of these types of tests, then you can move on to more involved tests of insulin action in vivo, such as the hyperinsulinemic euglycemic clamp. And so we'll start with the glucose tolerance and insulin tolerance tests, colloquially known as GTTs and ITTs. So here again, you have your mouse model with a suspected aberrant glucose phenotype. And for the GTT, the test typically involves fasting the mouse, and we'll talk about differences in fast duration a little bit later. Then you give a specific dose of glucose, which again, I'll delve into in a few slides, either intraperitoneally, intravenously, or orally. And then you measure the glucose excursion over 90 to 120 minutes, and you get a curve like this, where mouse models of aberrant glucose homeostasis will have an exaggerated excursion compared to control mice. The insulin tolerance test is fairly similar. You fast your mouse, you dose insulin either intraperitoneally or intravenously, and then you measure the fall in recovery of glucose levels over 90 to 120 minutes. And again, here you see an example, a normal chow-fed, lean, insulin-sensitive mouse will see a decline in glucose levels, whereas in a high-fat fed, insulin-resistant mouse will not see such a big decline. So first, I want to focus on some of the issues arising from how glucose tolerance tests are performed and how data are presented. One of the key things that is very typical in the literature is that GTTs are referred to as tests of insulin action or insulin sensitivity. And this is certainly not the case. As shown here, these tests are really not indicative of insulin sensitivity because the shape of the glucose excursion is regulated by at least 3 different factors. One is the pancreatic response to the glucose load, that is insulin secretion and also suppression of glucagon, insulin action or insulin sensitivity, and then also glucose effectiveness, that is the ability of mass action of that entry of glucose to be disposed of in various tissues. And so, what is really a diagnostic test used in the clinic has now become a quantitative phenotyping test in mice, but it has to be interpreted correctly in that it is not a test of insulin sensitivity. And so now getting into how these results are typically presented, I'm going to show examples, a pretty quick example of 2 ways that data are presented from GTTs. One fairly common way that these data are presented is as a percent of change in glucose from a set normalization factor, say 100%. And what you can see here is 2 groups, where group A seems to have a much more exaggerated glucose excursion than group B. And then so you would interpret this as group A being glucose intolerant relative to group B. But if we actually look at the same data, but instead of presenting the data as in relative to a normalized basal, showing the absolute rate, then you could actually not lead to the same interpretation that group A is more glucose intolerant than group B. The only difference being that the starting glucose, the fasting glucose level prior to the glucose tolerance test, was different between the groups. And indeed, these are the exact same data points. And the only thing that was changed was the starting glucose value. So really, presenting the data as a, normalizing to a fixed glucose level because your glucose level started differently might give you an incorrect interpretation of the results. And so really the correct way to, or at least the recommended way to present these data is to show the absolute glucose levels. And this leads us to, again, then what happens if you do have, whether you do have differences in starting glucose or not, then what is the best way to actually statistically analyze the data? And so I use this as an example because this is very typically observed in the literature where you have almost exact glucose tolerance excursions between these two groups, yet there is a slight difference at one particular time point. And then statistically, what is done is that t-tests are performed in each of these individual time points. And one interpretation of this is, oh, okay, here group A is glucose intolerant relative to group B, even though there's only a statistically significant difference at one point using a t-test, which is not really the way to analyze these data. Really, the recommended way to analyze these data is to calculate the area under the curve, and specifically the area under the curve above the baseline, because that takes into consideration whether there are differences in the incoming fasting glucose level. And what you can see here is that even though here, these two, one interpretation would be that group A is glucose intolerant, this is actually the area under the curve data from these two curves. And what you can see here is that there is actually no difference between these two groups. So this is the recommended method for presenting and then calculating and performing statistical analyses on glucose tolerance tests in mice. So moving forward to the insulin tolerance test, or ITT, there are similar issues with regards to presenting and interpreting ITT data relative to glucose tolerance. When you have incoming differences in fasting glucose levels, presenting the data as normalized to a set, where you normalize both groups to a set glucose might give you a misinterpretation of the action of insulin action because of that normalization process. And the recommended method is to present these data as absolute levels of glucose following the insulin dose. And another, again, looking at doing statistical analyses of individual time points versus here, it would be an area over the curve rather than an area under the curve. The area over the curve is the preferred method for analyzing these data. But one thing to consider, even when looking at the area over the curve, is that insulin has a very short half-life. And so even though this is a 90 to 120 minute tests, by the first time point, most of the insulin that's been given has actually been cleared. And so really using an ITT as a test for insulin action, really what one should focus on is the rate in the glucose fall within those first 15 minutes. And if you can take multiple blood samples within those first 15 minutes, that is advisable, because the overall shape of the curve beyond this initial drop in glucose is not only due to insulin action, but also the counterregulation that kicks in once you've reached levels where some of these counterregulatory hormones are active. And so sometimes seeing differences 90 minutes or 120 minutes after an insulin tolerance test is not necessarily indicative of insulin action, but really more of counterregulatory response. And so now moving on to more sophisticated tests of insulin action, such as the hyperinsulinemic euglycemic clamp, just to, this is, a gold standard for assessing insulin action in vivo, but to get everybody on board, what this test involves is giving mice a constant insulin infusion concomitant with a variable glucose infusion with the goal of achieving a set hyperinsulinemia, whether it's physiological or supraphysiological, while maintaining euglycemia. And this really allows you to isolate the effects of insulin independently of any changes in glucose. And this variable glucose infusion that is used to maintain the euglycemia is the first data set that you get, because a more insulin sensitive mouse will require a higher glucose infusion rate than an insulin resistant mouse. But then to get tissue-specific insulin action or flux information, then you can also infuse isotopic glucose tracers to get readouts of endogenous glucose production, glucose disappearance, and then tissue-specific glucose uptake. And this is just a schematic of a protocol for a typical clamp where mice are fasted, the isotopic glucose tracer infusion is begun, blood samples are taken at the end of the fasting period to get basal information, and then the clamp period begins with the constant insulin infusion and the variable glucose infusion. And this variable glucose infusion is determined by taking blood glucose measurements at specific intervals, say 10 to 20 minutes, and then adjusting the glucose infusion rate accordingly to try to maintain euglycemia. So with that in mind, some of the recommended data that should be shown in all publications using this technique. One is the time course of the glucose levels, and this is an example of just looking at lean controlled chow-fed mice and obese insulin-resistant mice that were fed a high-fat diet. Since when this experiment is performed, you have to take glucose measurements at specific time intervals. There's really no reason to not show these data, contrary to the typical approach that's seen in many publications, which is to show averages at specific, like say the last 40 minutes of the clamp period. But this, showing the time course really gives the reader an idea of how well euglycemia was maintained throughout the study. And same with the glucose infusion rate. These are time points, these are data points that are obtained throughout the study. So there's really no reason to show an average. And this gives the reader an opportunity to see how steady that glucose infusion rate was during the study. Reporting insulin values is extremely important, and it's surprising how many studies, publications where these experiments are performed do not report either fasting or insulin levels at the end of the study. And this is important because you may have a model where the incoming insulins are different, and therefore, even though you're infusing the same amount of insulin, you may end up with different insulin values at the end. And so that definitely changes the interpretation of the results when you have differences in either incoming and or outgoing or clamp insulin levels. And then if tracers are used to measure things like hepatic glucose production, typical way that this is expressed in the literature is to express it as a % suppression from basal. But again, oftentimes your incoming rates of glucose production may not be the same. And so by presenting data as a % suppression, you may get an incorrect interpretation of the data. And same with full disappearance of glucose uptake into tissues. It's oftentimes you see this presented as fold stimulation, but if it's the incoming rate of disappearance is different between your groups, then your fold stimulation might give you, or presenting the data as fold stimulation might give you an incorrect interpretation of the data.
1 minute remaining.
Okay, and then when presenting tissue-specific glucose uptake, it's important to specify the actual tissue from which these data were generated instead of saying something like generic muscle glucose uptake. I'm going to basically skip through this. So some key parameters to report in publications besides some of these are parameters that Alex already described for energy balance studies, such as traits that are inherent to the mouse, environmental or factors such as light dark cycles, housing temperature, and breeding schemes, and then procedural parameters such as fast duration, how the dose of insulin and glucose is calculated for these various studies, and then the method of sampling. And unfortunately, I've run out of time to really go into this, but I just want to highlight the fact that fast duration does influence the outcomes of studies, including glucose tolerance tests and clamp results, and the dosing calculation. Oftentimes, these doses that are given to mice are calculated based on their body weight, but in obese mice that actually might give an obese mouse a much larger dose than it ordinarily should get. And so one recommendation is to give doses of either insulin or glucose based on lean mass if that information is available, or to do what's done in the clinic and to give a fixed dose. And so there are specific deficiencies in the field that I've outlined, and it's been the charge of the MMPC, specifically at Vanderbilt. We've put out several position papers describing these deficiencies and recommendations on how to fix them. So with that, I'll thank you very much.
Yeah, another wonderful talk. Thank you, Julio. We now have time for a few quick questions before the break. For audience who cannot unmute yourself, please feel free to type your questions in Q&A. And for panelists, feel free to raise your hand or just unmute yourself. We do have already an excellent question posted in Q&A. The new recommendations are great for future data reporting. What about the enormous amount of data already generated in the past, which probably haven't adhered to any CDM, I assume standing for Common Data Model? So yeah, what do the speakers think?
You want to go first, Alex?
Yeah, I think that the questioner's assumption is correct, that once the paper is published, people usually wash their hands of that study. It would be on the onus of the authors of that study to go back and to deposit them. I think there could be a role for the NIH to ask people to go back and take their previous studies and put them in the public domain by sharing the data. But I think, and the approach that we're taking with our consensus energy balance model is just moving forward to try to be better going forward. And you can learn something from the past, but with only limited insight.
Yeah, I agree. I think once, Pandora's box is open, it's kind of late to put all the spirits back in, but I think it is incumbent on us as, when we are publishing our work, but also when we're reviewing the work of others, to have these recommendations in mind. And, if it's a head-to-head comparison with an older study, to take that into consideration, how the data from the older already published study were presented, normalized, et cetera, and take that into consideration.
So I have a question for Julio, if I may.
Sure.
Because so there are so many glucose tolerance tests in the literature. Is that a data format that you think should be shared, the raw data from those studies? Or do you think it's just too much? Is that a bridge too far?
I don't think, compared to other types of, for example, omics, it's not, I don't think it's a bridge too far to present, the metadata and the, individual time points for all the mice, because in particular, these tests usually do not require a huge number of mice. So I think that, one of the pushbacks that I've heard in the past is, well, there's limitations to number of figures and pages, but with supplemental sections now being what they are, you can definitely include those data. Now, if you get into performing glucose tolerance tests, for example, with a continuous glucose monitor, then that can become a little overwhelming, but I don't necessarily see that as the norm going forward. I think glucose tolerance tests will still be done with time points every 15 to 30 minutes.
And there are no data standards for preclinical continuous glucose monitoring.
Correct.
So even if you were to report it, it's not clear how you would do it and what your metrics would be.
Right.
Yeah, Shankar posted a question. Shankar, would you like to just
I would love to get an answer, both Julio and to some extent Alex. Batch correction becomes an important issue in measurements. How do you deal with batch correction? Do you have, for example, statistical tools that have been developed in this case for batch correction?
Yeah, that's a tough one, especially, you know, when we are dealing as a core facility that takes performs these tests for other people. And, you know, we have seen variability from one batch to another. And so, you know, obviously the ideal and the recommendation is for, you know, generation of mice to be such, and it does take a little bit work on the front end to generate a large number of mice so you can do all of these experiments in a single, you know, relatively timely batch versus you know, one and then one set of studies and then another set of studies 6 to 8 months later. Because we have sometimes seen that as an issue. And you know, we've sort of scratched our heads as to how to deal with that statistically. And we haven't really come to a consensus on how to do that.
So building linear mixed models and looking at some kind of variance-based approaches towards analyzing data could be an interesting way for you to look at batch correction. I mean, we have adopted such methods for a large number of other studies, not your type of studies, but more omic studies. But this could be valuable for you to think about. Otherwise, we are going to perpetuate noise and errors as we supply more data.
Right, agreed.
Yeah, there is a question from Danny to Alex. Danny, would you like to just ask directly, unmuting yourself?
Sure. I think it sounded like ease of use was one of the key factors for the users of the repository. And I was curious if you employed any customer discovery or user testing strategies to ensure that you'd have good usability or adoption from people coming with the wider range of experimental methods and devices, et cetera.
That's an excellent question. So right now there are 3 main manufacturers of these devices, and they have different data formats and different data units. And so CalR can read in data from all of those. But really about the user experience, what we've been doing is what's called dog fooding, where you eat your own dog food. If you sell dog food, you feed it to your own dog. So we use CalR every day. And so for every type of experiment, we try to make sure that CalR really fits the need that it has to fill. And because of that, we keep optimizing it because our developers are right here and they're 2 doors down from me. And so we can just go in and say, hey, can you fix that? That doesn't work quite right. And so because of that, we've used it in a lot of different aspects, and it's a web app. And so people can just upload their data. And if they have complaints, they're not shy about emailing me and saying, can you please fix that? Or that doesn't make any sense, or can you explain it to me? So if I have to explain something more than 2 or 3 times, that's really the impetus for me to fix it. So we test it a lot, and we get a lot of feedback from users because it's used like 1,500 times a month. So we get a lot of feedback, which is nice. Thank you for the question, Daniel.
Yeah, thank you. Ashley?
2 great presentations. Listening to these 2 presentations, it's occurred to me that you show 2 very successful models in terms of how to implement the standards. Alex showed that the community develop a standard and they build actually resources when people submit the data or use your tool is a way to enforcing the community of great standards, right? And Julio, the MMPC basically, by centralize the complicated assays in one central place that provide the services for the community, that's also a way of enforcing the standards. I just want to comment that I feel this is a very good examples. Thank you.
1 minute remaining.
So I want to say that the Spider-Man with the funding agencies and the academics, it was Shujing. I was asking her, what do you think we should do to establish standards and to make sure that everyone is we kind of know what we should do, but not everyone's doing it. Mm-hmm. And she said, well, it's not going to be the NIH telling the world what to do. It has to come from the academics, right? Which sounds obvious in retrospect, but at that moment I was like, no, this is something you should do. But
we facilitate
yes.
Community interest, but ultimately I think it's the community to decide on the standards. and etc. And we can promote adoption, sharing, etc. Facilitate the community to reach a consensus. For example, yeah.
Yeah, I agree. So that was a very useful conversation. It was something I needed to hear.
And again, this is part of the mission of the MMPC as an NIH NIDDK sponsored consortium. We're not perfect by any means. This is a battle that we are still fighting 20 years into the program.
Thank you both. I do have a couple of questions also, but in view of the time, I will save them for the panel session. We're at 3 o'clock, so we will take a 15 minutes break, and then we will reconvene at 3:15 for the last session, which will be a panel discussion session.
Okay, see you then.
Thank you all. See you soon. Okay, good afternoon, everyone. Thank you for coming back, and welcome to the last session of today, which is will be a cross-cutting panel discussion that will address the gaps, challenges, and opportunities with integrating and implementing data and metadata standards across NIDDK research areas. Our moderator for this session will be Dr. Jeff Grath. I will be assisting Jeff. We will be joined by our speakers from all 3 mini sessions. So first, let me say a few sentences about Jeff. Dr. Jeff Grath is Associate Director for the Center for Research in Biological Systems at UC San Diego. He is the contact PI of the NIDDK-funded NIDDK Information Network, i.e. DKNet, which serves the needs of basic and clinical investigators by providing seamless access to information and the resources relevant to the mission of the NIDDK. I actually have the pleasure and honor working with Jeff for the past maybe 7 to 8 years on DKNet. It's a lot of fun. Jeff has been involved in the development and the implementation of data and metadata standards for data repositories, and is also involved in NIH programs developing preclinical common data elements. He has more than 2 decades of experience in providing informatics environments to biomedical researchers in order to advance scientific inquiry and to enhance scientific rigor and reproducibility. So, Jeff, let's get started.
Thank you, Sujay. From the talks today, it was an excellent session. There was some common themes that seemed to percolate out of, all the presentations and sessions, and that really is sort of this idea of the need for standards, potentially core common metadata standards, right, for both clinical and preclinical, and then the lack of, specialist repositories to house this data. Right. And so I think, Suching mentioned, NIH can't lead these efforts. And as Alex mentioned, that comes down to the researchers. But there is, I think, a synergy that can happen between NIH and Alex. And so I just wanted to sort of highlight, some of the activities where, we're developing common data elements, metadata on the preclinical side, but we do have NIH support in terms of coordination among projects. And so this is across, 3 separate preclinical domains. Actually, it's through NINDS, but the work from NIH is really to help coordinate the efforts, provide sort of best practices in how to promulgate these common data elements to, for example, the NIH Common Data Element Repository, but also to help align these groups so that, for example, that we do come out with a set of common core metadata elements across these various groups, in addition to the more specialized common data elements are required for specific types of experiments. So I think, there is a sort of a synergy between, sort of the academic community, research community, and NIH, in terms of, how this can potentially, move forward. But getting back to sort of the common sort of metadata standard, which Shankar, had raised, to begin with, and then sort of, Alex, you'd mentioned sort of the work you're doing with the common data elements as well. I mean, in the next sort of 5 years, I mean, what do you think are sort of the critical steps, needed to sort of build out, this sort of set of common data elements and get them, picked up in the community to be utilized, in the community?
Yeah, so part of it is trial and error. So with CalR, the very first version that we launched, it wasn't great, right? And we would use it and we would keep reusing it and then keep modifying it until it made more sense, was more intuitive. And I feel like the common data elements for indirect calorimetry and for this repository, it's kind of going to go a little bit like that, where we're going to open it up with the list of metadata that we had listed and all the data formats that we think are going to be really important. And we're going to try that and see if any of it makes sense. Maybe we don't have enough quality control in the input part. And I feel like after 5 years, like 5 years from now, I think we're going to have a really much deeper analysis of what are the important data elements and what's not so important. I mean, is bedding going to be important? Is the housing density going to be that important? We don't really know. And so we're going to start by trying to collect everything. And maybe over time, we'll figure out what's really important and what's not. Physiology is really hard, right? There are so many variables and it's so, there's so much intrinsic variability that we won't know until we get a whole lot of data together. And I think that's the goal. And I think that's what we saw across all of these talks, is that physiology is just really hard to get a hold of, like what are the important elements and what isn't so important. I love the example that Claire said, that where she was talking about how different people would interpret the same analysis, the same plot very differently. Like her colleagues would have very different opinions about what the most important parts of it were. So I feel like we're not going to know until we give this a try and just let it go for a little while.
Yeah, Shankar?
Yeah, I mean, I completely agree with Alex. I wanted to make a couple of quick comments and then pose a question to actually NIDDK folks. And so the comments are the following. The comments are that, number one, I mean, I think having, common metadata elements is important, but context becomes very important, as Alex pointed out in his cases and a lot of examples. My only plea to all of us is to either use the ontologies that are currently accepted and existing or controlled vocabularies, which can be perpetuated. Alex, you're doing that with your controlled vocabulary development that you're doing, and Julio was mentioning it as well. So we can use controlled vocabularies and ontologies so that we can make it as standardized as possible, or at least interconvertible in some meaningful format. And to me, there would be a very strong recommendation that this workshop should make in terms of developing common metadata elements. Number two, this is a question more open to NIH. NIDDK. Is it worthwhile for NIDDK to consider forming a few select working groups? It doesn't require funding really a lot because there's a lot of community interest in this area. A few working groups, one focused, for example, on phenotypic data, one focused on omics data, one focused on clinical data. And so we can really have these working groups, small working groups, 4 people, 3 or 4 people. I mean, people like Jeff have tremendous experience in doing these things. And so if we can have these working groups to meet, come together at some point, harmonize, and then help in terms of building a larger NIDDK recommendation for DK researchers, in terms of following some standards for metadata and data, and for making it available. This would be a very good move from an NIH point of view, in my opinion. You can tell me all of us is trying to do it, but all of us is a little bit more nebulous compared to a focused, effort in terms of where we want to go. And I think it might be, I don't care who gets the label or who gets the credit, but if you can do it, then the community will benefit in the long run. So that is my humble opinion for NIDDK to really launch such an effort. And I'm sure you can find enough people who will volunteer or contribute or help. It doesn't have to be a, weekly meeting. It can be, once a month. We can think through, put ideas together, and then have a common site like a Google Doc or some site like that, where we can contribute to this. So this is my suggestion for you folks to think about. I have a couple of other points, but we'll come back to it after I'll give chance to others to talk and then come back later on to discuss more.
Yeah, I just want to quickly say thank you, Shankar. It's a wonderful suggestion. It's actually related to a question I was planning to ask the panel. That is, any suggestions of how we can facilitate. We definitely want to facilitate development of common data element and data standards, and also adoption and the usage. Actually, in your concluding slide, you listed 5 items. One of them is like use cases going to be important. I was also going to ask you how, whether you can have more specific recommendations in terms of how do we act, how the whole community and us together can act on things like that. So it's thank you. I took a note. Yes, thank you.
Yeah, I posted these questions on the chat for everybody to look at. Posted the actionable items.
Yeah.
I'm a fantastic believer in use cases, Shujing. Thanks for bringing it up. I think community learns through use cases. We all construct, things through use cases. In the Common Fund data ecosystem, we have been instrumental in developing about 30 or 40 use cases, which are really across board, which really ask the question, how can a user use data and tools to learn or build knowledge? This one working group I would recommend that you can organize would be centered around use cases. And we can create a wiki where the community can engage in posting use cases. This is a wiki resource. We can call it as a DK wiki, DDK wiki. And so this can be a community open standard. It can give rise to new programs, new plans, new ideas, and so forth. So it's something to think about again.
Right. Certainly, we totally agree. I just want to quickly share that DKNet, which I mentioned, which has Jeff as the contact PI, does have this as one of its charges, like help community to develop use cases. And another community resource program called the PancBase, standing for Pancreas Knowledge Base, is also charged to engage the community in developing use cases. So very happy to hear that you are recommending this. So means we probably on the right track. Wonderful. I just want to quickly comment as it's related to my other question for the panel. That is, our speakers from different disease research areas focus on different human body systems. It's at some stage probably integrated view or study needed. A lot of common conditions are related. There are many comorbidities, etc. So it's at some stage we need to consider whole body health, the whole body system. So I wonder whether this, these various data standards efforts should communicate across the different specific body system domain and disease areas also. Yeah, it's something. Wonder whether we could help with that, or do you think that's needed?
Well, I think, from the discussion around the different types of metadata standards, right? So there's sort of the core set of standards that, that may be more common, right, across different systems. But if you get down to, the specifics of the data being collected, with the data, that were shown around, the urology data, or, what was shown with the colorimetry data. The data, when you get down to that level of detail, you're going to need specifics around that data and standards. But not having to redo the common core metadata over and over and over again, it is something that hopefully can be avoided. And some of the common metadata is being developed by other groups already, right? So NIH does have working groups, for preclinical common data elements, in other domains. And so there is a set of potentially common on the preclinical side. Clinical side, there's also work going on. So, I mean, I think leveraging what's been done in the past and also leveraging the user stories of how that was done, right? So how the working groups were run. And again, one of the things with some of the groups I'm working on now is, how do you get, for example, the preclinical metadata standards into some of the NIH resources like the NIH Common Data Element repository, right? So there's a repository for these common data elements, but it's been very heavily clinical focused. And so, we're working with them in terms of how do we bring, these preclinical data element definitions, to that repository.
I'll just add on to that. I think the importance of, I get a little nervous about this notion that we're going to all of a sudden reach out and hold hands and figure out this specific thing for things that I do think get very specific at the end, but to highlight that the wins and to say, look, this has been really effective elsewhere. Are there broad lessons that we can learn? I find that it's hard to be aware of those things and to get that. And if the NIDDK can facilitate saying, look, we've been really successful with this group doing it this way, here are the lessons that they would like to share. I'd love to hear them for what it's worth.
Okay, so one of the other topics was brought up that there isn't always a place to put the data, and if standards are developed, usually within specialist repositories, right, the standards are basically evaluated when the data is deposited, right? There are routines or curation to say, yes, you are adhering to metadata standards. But this gets more difficult if there is no specialist repository and you're using some of the generalist repositories. So what are some thoughts on how that could potentially be changed? I know that, for example, Dryad has been experimenting with community curation or moderation of data and metadata. But just thoughts on how to actually make sure that these standards do get used, once they are actually developed.
Jeff, if I may comment on aspects of this, let's talk about data, which is, granularity of data is very important, right? If you talk about omics data, there's a lot of resources already available, public repositories where you can deposit these things. When it comes to phenotypic or clinical measurement data, that's where it becomes very complicated, or even if it is imaging or cellular assay type data. As you know, for example, Bridge2AI is an NIH project, which is really developing a lot of imaging and voice recording and things like that. And how do you present these data and where do you deposit this data is a fundamental question that needs to be addressed. It's not clear to most of us. One thing that NIH has recommended to other agencies is to develop, cloud standards so that it can be placed in cloud in some meaningful ways in a Dockerized format, along with some apps which can be accessed at some point. The question is, so how will we sustain it? And this is an NIH question. This is not a academic community question. How do we sustain this data in the long term? Because of most projects funded by NIH have 10-year time frame, 5+5. Then at the end of 5+5, what happens to these data? And this is a question that needs to be addressed at a larger level as to where we want to go. And then the last point I want to mention is clinical data, which you're referring to. And clinical data is another area where electronic health records in each hospital or clinical system maintain the data. The question is not so much whether the data can be stored. The question is whether the data can be accessed. University of California system, Jeff knows this very well. All UC schools now hospitals have a common way of accessing the EPIC data that the electronic health record system maintains. Can we broaden the scope through the aegis of NIH and help from NIH to extend it to beyond just the UC system or some specific system. So this is a question that needs to be raised at some level. So I hope, Jeff, I have started to address some of the issues that you're raising.
Yeah, Alex, your hand raised.
I've got a question about data repositories. And as we start to accumulate this data, one of the questions that comes up, and we see issues of quality control, where if someone has a system that's poorly calibrated, and let's say we already have data from 1,000 subjects, and you upload a new data set, and it's off, right? You can tell that given the metadata that's uploaded, that data is not of the same quality as the other ones. Is it, as someone who hosts a repository, so this would be for Shankar, for Jeff, is it on you to then exclude that data from the repository or to flag it in some way to say that it's failed a quality control? And then, what is the onus on the person who's running the data repository for quality control and for curation?
Yeah, so I mean, if it's, again, for a published study where the data is accompanying that study, I mean, on the imaging side, I've seen repositories do their own sort of quality control, right? So there's some standardized quality control metrics that they can generate, and they produce those consistently across all data sets that they take in, right? So that for each data set, there is then sort of this set of quality control information that is associated with it. So that's one way of sort of addressing, issues, of quality. There's also potentially, a curatorial aspect to that, in terms of, when data sets are being published, interacting with the investigators and saying, we've done some of this, and there seems to be an issue with, these measures, that you have, but it really depends on the, on the data. So it gets very difficult if it's not. Again, if it's not a specialized repository for that data type, because then it's just such a large problem in terms of determining, as the talks today showed, right? Each of the sessions had different ways, in which, the data, could be interpreted, in one way, but, there are potential caveats there, right? In terms of the difference in the instruments, the measures that were given, or the difference in the way, Alex, you were saying, in terms of how the data is calculated, right? And that's all very domain specific.
Right. I understand. It's something that I worry about, even though we haven't started collecting our data yet, about how we curate the data so we have the most useful final set. And we have data that passes all of our quality control metrics, but if someone's published their study and they say the data are available in our specialized data repository, we need to make it available, but maybe it's flagged with a quality control that, there's something about it that seems unusual or something. So it's still available, but it's been flagged.
Yeah, I mean, in a sense, you could provide sort of a set of, quality control metrics, for each of the data sets, and make that available. I mean, I think bioRxiv was also trying something like that, where they had certain rigor and reproducibility criteria that they were providing information on. So,
yeah, this is a little specific to the energy balance, metabolic gauge systems. I don't know about some of the other manufacturers, but I know that Sable, in their, metadata report, there is a tab that basically captures all of the things that failed quality control during a run, RERs that were off, or flow rates that were not within the expected boundaries. So I'm wondering if that's something that can be included in the data repository. I don't know if the other systems, if the other manufacturers also include those reports.
So that doesn't really bother me so much, because so in the cage measure is measuring the area inside the cage and outside the cage, and the differential tells you how much oxygen was consumed, and that's fine. And when you open the cage to put the mouse in, or to refeed the food, refill the feeder, the values go crazy for one measurement, but it's every 2 minutes for 5 days. So, okay, my 1 2-minute measurement failed, quality control, but it's irrelevant compared to the thousands of other measurements. So I don't know that we need to record every time something was wonky, right?
No, I'm
Yeah.
talking about like for entire runs.
Oh, for the
When you have an
entire
I mean, I have seen publications of, folks publishing an entire run with RERs of 0.5,
Okay.
where you know that there's a leak in the system or something, and
That's
because
impossible, right?
the investigators or the reviewers are not knowledgeable, they didn't question it.
Okay.
Yeah.
That's a fair point.
Jim, I see your hand raised.
Yeah, this reminds me of, and I unfortunately I didn't bring it up because I don't really have any good idea for it. One of going to the next step in my mind is some sort of analysis of this, and I think this question of flagging is getting at some sort of analysis thing and a pre-processing of it. Particularly for our time signal domain things, though, there are a lot of artifacts that are in it that are sort of expected. They're very hard to get around. And one thing I've struggled with is coming up with any sort of language for analysis of marking up and interpreting data and how to do that in some meaningful way and get standards, particularly when it comes to analysis where it just seems a lot more fluid than other things. So this is something I'm struggling with right now is coming up with languages for this thing started too late or started too early, and then ignore this region, don't ignore that region. This one is elevated or whatever. And again, I'm just starting to think about this, but I figured I'd bring it up because it reminded me of the quality control thing.
Yeah, so I mean the issue of sort of these curatorial tags, right, in terms of what it means, and how that can help sort of advise people using or looking at the data. Shankar mentioned that there are some ontologies that are being developed, right, and some of them actually do focus on sort of these curational issues. It's definitely something that can be worked on down the line.
And I guess I didn't know if there's if you could have like Jim's analysis version where like run Jim's processing pipeline, and then other people could like have easy access to that as like a, or no, I prefer Claire's processing pipeline, something that's a little bit further down and then sort of recontributed back, or if that needs to be just completely separate from the original data and then everyone sort of does their own thing. I don't know.
Yeah, I mean, again, different repositories have different mechanisms for including sort of derived data. And so it might depend on the repository. If it's potentially clinical data, right, that has, PHI concerns, then it is a, very specific process with potential data repository, right, or the data resource that made the original data available, if they even allow the data to be contributed back. And I think that is an issue that is also important, as people run, different processing or you said different pre-processing, right, to make that data available so that it doesn't have to be done again, or, that it can be made available. And, when we start talking about, development of large language models, how can those models be shared in an effective means so it isn't, trapped in an investigator's lab and has to go through many hoops? Is it possible that some of the repositories and data resources that already make this data available can make that as sort of this derived information available as well? And Shankar, I see your hand raised.
Add to Jim's point, I think there are beginning to be data workflows, APIs for specific problems, which are now beginning to be available and made. GitHub, for example, has a number of those. And it may be worthwhile for a community like yours, Jim, to collate some of these workflows and APIs and make them available to the community. And that would be fairly useful at a larger level. This actually brings me to a question for NIDDK again. I know that when we write a proposal, we have DMSP, which is data management and storage plan. My worry about that is it doesn't have enough granularity. That's where there's no question asked with reference to what control vocabularies, ontologies, or standards will the data be used in, what specific access to workflows or tools will be made available To elaborate on that a little bit, make people who write proposals work a little bit harder, think a little harder in terms of how they will make data useful down the road, could be very valuable. And I have raised this issue with other institutes besides NIDDK. It's not specific to NIDDK, but you can take the leadership role in terms of making a DK specific, MSP page.
How to enable the community to leverage data science more, how to promote more reuse of our high value data sets, etc., touched upon these type of things. Yes, I will just note, I will bring it back to our leadership and also our data science working group. Yes, recommendations from you guys help us out, gives discussions more weight. Yeah.
I think.
Yeah. So I mean, I think again, it depends on what the purpose of the study is, and so for example, in the MR domain, in terms of being able to do better and more fine-grained track tracing studies with DTI definitely improves with a magnet strength, and you can have faster sort of functional time points. Does that always mean that the older data is not useful? Not in all cases. So there are these technology drivers, but still, I think that's also where the common metadata comes into play too, right? So if you're looking for studies, right, you want to make sure that all that information about what the field strength is, what the coil is, for the imaging data, that is all there, so that you can take that into account, based on what you're looking at.
I just want to add a small point to it. I mean, Claire, in terms of MRI and other imaging, clearly the context is the tissue. The context is anatomy, the location. So if we don't have a metadata annotation associated with anatomy and tissue and a coordinate axis of location, we will not be able to, even if the technology has improved fine-grained at a pixel level, we have a different resolution. We can warp the data as long as we have an anatomical context and a coordinate context. So this is something that people are beginning to, in the MRI world, people are beginning to appreciate quite significantly at a level of backward tracking all the data to integrate it.
Okay, and I think, are we running up against our time?
You can finish up.
Okay. Well, I mean, I think we've had a good discussion, and there are some potential ideas for moving forward over the next few years in terms of developing some of these standard metadata models and leveraging lessons from the past. So I look forward to seeing that progress. So, Sujing, did anything you want to say in closing out the session?
I guess just want to thank our speakers and the panelists. It's a wonderful discussion. It's super informative for the NIDDK. Thank you all for your contribution, for your service. Thank you.
Thank you for having us.
Yeah.
Well, thank you all for the active participation and thoughtful contributions. This concludes our first day of this metadata standards workshop. I wanted to make a few highlights for today. If you can put the slides for today. This morning presentations establish the current state of the data standards, showcase a few success stories in data collection and integration. Our panel explored both progress, such as the work that on the development of the I-code, and we also touched on persisting gaps in integration and implementation and interoperability, including some of the inconsistencies in adoption of standards and multiple device manufacturers. So those are some of the things that we found. This afternoon, we focus on the adoption, integration, and implementation topic. Some of the things that go across NIDDK specific disease areas, while also learning about ongoing challenges, again, with inconsistent implementation of data and metadata standards, as well as the latest advances and opportunities. Our cross-cutting panel emphasized the importance of collaboration across projects and sectors. We really know that it takes a village, and we highlighted the need to harmonize and develop standards where gaps exist with specific recommendations that we heard from our panelists. Next slide. As we look into tomorrow, we will be going deeper into the integration and interoperability of data and metadata standards, exploring both traditional and technology-driven approaches to advancing the field. We will also discuss building partnerships to facilitate the adoption of data and metadata standards. We will also hear from our keynote speaker tomorrow, from Avinash Shanbhag, who will set the stage for more actionable discussions. I will thank you again for your insights and the energy for the conversations we had today, and look forward to seeing you tomorrow morning at 10 a.m. Eastern Time. Thank you.